That was the mistake I made. Now, had I done that, I think I could have avoided metastatic disease. 1 out of every 8 men will be diagnosed with prostate cancer in their lifetime. Nothing's going to hurt when you have prostate cancer, okay? Nothing's going to tell you. There is no pain, there's nothing. Asymptomatic inside the prostate. If it is symptomatic, that means it's outside the prostate, and that means you're in trouble. The hard conversation, I think, for men, because you don't even want to talk about it with your wife, is there's a chance I may get ED, permanent ED. Men who get metastatic disease are still dying from prostate cancer, losing about 35,000 men a year, death by prostate cancer. About 275,000 men per year getting diagnosed with prostate cancer. It's interesting. I'm an attorney, and they literally declare attorney-client privilege with me. They'll say, I want to talk to you about this, but this goes nowhere. Nobody. I mean, I'm not kidding. That's mostly how the conversation begins. They don't want anybody to know that they have prostate cancer or that they fear these things that we're talking about. So, yeah, I have a very open conversation with them, much like I'm having with you right now, about everything that's going to happen. What I hope you learned today is your PSA number is very important. And if your doctor is going to tell you it's normal, say...
So today I have the honor of getting to be with Joe Dooley. And Joe, when I came across your story, I think what fascinated me most about the whole idea of prostate cancer is how it's something that most men don't talk about. They don't want to talk about. And here I see this video of yours on YouTube, and there you are up in front of your friends, and you're sharing so boldly with such conviction about your story. What led to that decision?
I am one of those men, definitely, who didn't know anything about prostate cancer. When I found out I had it, I didn't want to talk about it. And as I went through the process and had metastatic disease and had all this treatment, men would ask me a lot of questions about it. I realized they only wanted to have a private conversation. They didn't want me to know or me to tell their wife or any friends. This guy's trying to keep it private just like I did. But I also learned that they would ask such questions as, what is the prostate? What is this PSA test? What lies ahead for this? How does it get diagnosed? They would ask questions. I realized, just like me, they know nothing about prostate cancer. And over time, a few of these men would go and get a PSA test, find out they had prostate cancer, get their prostate out, and be cured. And I realized, okay, now I'm helping people who didn't have knowledge, or just like me back when I got diagnosed. Why am I keeping this into private conversations? It's time for me to step out, jump off the cliff, and spread the news, because men in the patient position are not spreading the news amongst each other. I think the perfect example of the opposite is the way women handle breast cancer. When breast cancer just started to become rampant in younger women, there was a dynamic force, the way the women gathered around, their dynamic community, they get around each other, learn about it, talk about it, spread the word, do walkathons. They have raised over $1 billion a year for breast cancer. How many people have been on a prostate cancer walk or to a prostate cancer fundraiser, or got a letter from a friend who said, can you help me support the Prostate Cancer Foundation? Men just stay quiet on a disease that is the number one cause of cancer in men, and they're not talking about it. So I thought, I'm going to go ahead and just get out there. It's give up my privacy and talk about it and try to help others through education, but definitely awareness, so that they can get early diagnosis and treatment of the disease, which can be cured if you get early diagnosis and treatment. It's incurable if it metastasizes.
So just real quick, what was that journey like for you of like, I'm having these private conversations with men? Are you starting to tell your wife like, hey, for some reason, I think maybe, I don't know, maybe my voice needs to be heard in more than just these private conversations. Was it something you were kind of reluctant to take that step? Was this over like a few months? Was it over a year?
It's been well over a year. I mean, I was having these private conversations when I was diagnosed with metastatic disease in late 2020. I didn't tell anybody I had prostate cancer until after I was diagnosed with metastatic disease. I kept it quiet all the way up to surgery. I told only a few friends, next week I'm going in for surgery, and this is what's going on, but I'm sure I'll be fine. And that group of friends, and I'm talking about like 10 guys that I told who were my best friends that I thought would want to know, and I'd feel guilty if they found out I had, surgery I didn't even tell them about, especially if they're calling me to play golf the next week or something. Like, I can't, I just had surgery. I don't want to explain it afterwards. But I still kept it very quiet. But once it metastasized and I told people about it, so men started asking me about it. Well, how did you first get diagnosed? All those questions I was talking about. And I still kept it private. And then literally this year, I went to a talk, a lecture, a presentation. I don't know if people heard of Mel Robbins, but she has this whole let them theory. And her message is, let them think, let other people think what they're going to think. You should do what's right for you and what's right for helping other people. And I thought, why am I holding back? She's right. I'm sitting here worried about what other people are going to think when I'm talking privately about my medical issues. And really what I'm trying to do is help others. And that's a good thing to do. So I'm just going to go do it. So here I am.
Okay, so a Mel Robbins inspired talk. And from hearing it to action, are we talking like months, weeks?
That was in May. I left her talk and started looking up various things about how to do TED Talks, how to do a podcast, how to get your message out. And kind of all came back to the first thing you need is a video to show your speaking ability, talk to an audience, that sort of thing. I thought, well, I can do that. So I gave a talk to some friends who wanted to learn about prostate cancer and started with the video. And here I am with you. We're just on the beginning of the journey. That was in June when I started, and here we are in August. So this is brand new.
I just think it's amazing. And I think that's why I'm wanting to press into this, Joe, just to honor you for a moment, because I interview a lot of different, founders, CEOs, pioneers, and so many of them lament that they had ideas and they have had ideas for so long, but finally they decide to just do something about it. And they decide to just, bet on themselves. And here, this isn't just simply like an idea. This is a compromise of your privacy. And prostate cancer is this whole area, like you said, that's kind of just been in the shadows. It's not breast cancer. We don't talk about it. For men, it's kind of like oh man, I don't know if there's just some weird shame because no one's talking about it. Like this weird, like, hopefully no one knows, no one finds out. And for you to just step up and say, you know what? I'm not willing for other people to stay in the dark. I want to sound this message so that people can actually learn what I didn't know, go for early detection, and really go for a cure instead of the experience of metastatic disease, which we're going to get into. I just think that's amazing that you've been so action oriented. The second you realized, I think my voice can make a difference.
I think men, as much as they joke about it everywhere, golf course, locker rooms, everything about their sexual organs, the only way they can talk about it is in humor or dirty jokes. They don't want to talk about what's going on down there at all. Prostate cancer is all about anus, the rectum, the prostate, the penis. Those are words that you're not going to talk medically about with your buddies. So that's the problem. You asked about the inspiration. I don't want to forget about my friend Kevin, because that's when I started thinking about it. It was in September of 2024. It took me till May to get out of my chair and start doing something. When I was diagnosed and getting ready to make a decision, should I do a prostatectomy or radiation, my wife actually had a friend and client who had just gone through surgery. His name was Kevin, and he agreed to talk to me. no problem. So he told me all about the surgery, why I need to have it, what I need to do. And we became friends post-operatively. I talked to him. He called me, how you doing? These calls would go on for years. Then he got diagnosed as his PSA was normal. Then it came back, which meant he had a horrible, aggressive metastatic disease. And he fought it. And I was with him. We talked for throughout the years, 2021 through 2024. All of a sudden, lost sort of contact. He didn't respond. He was always a quick responder. We talked all the time, and we learned in September. We got a call from his wife that he had died of metastatic disease. That was really hard, and so I've been on it in my mind since September. What are we going to do? What can I do to keep the message going? I mean, this guy helped me. I've helped others, but how do we get it out so this doesn't happen to men? And then, like I said, I saw that talk, and I realized I'm going to do it. That was the other part of the inspiration to do this.
That reminds me of the misconception. Men don't die from prostate cancer. They die with prostate cancer. Do you want to take a moment and speak to that?
One of the worst things I think the doctor can say to somebody, and they say it all the time. It's just like this. It's like trite and cliche. It's one of those things like, stitch in time saves nine. It's just something people say. Maybe you don't even think about it. Men who get metastatic disease are still dying from prostate cancer, losing about 35,000 men a year, death by prostate cancer. About 275,000 men per year getting diagnosed with prostate cancer. 1 out of every 8 men will be diagnosed with prostate cancer in their lifetime. Black men have a higher incidence, at 1 out of 4. Young men are getting it, especially if they have prostate cancer in their paternal line. So to tell people this is nothing to worry about, which is what the doctor's saying, it's reassuring to hear. Don't worry, this is a disease that people die with, they don't die from it, is wrong, because it sets in the mind frame of the patient that I don't even care if I get prostate cancer. It's just something you live with. You don't have to worry about it. Well, you do need to be on it, and you do need to worry about it. And the reason you need to worry about it is because it's curable. And to think don't worry about it puts you into the metastatic category, when if you catch it early and treat it early, you can be a guy that's going to live your normal life expectancy without prostate cancer. Why live with prostate cancer when you can have it for a moment in time and live without it for the rest of your life? That's what doctors should be telling them. Not, this is something you can live with. How about let's work on living without it?
So tell me about the start of your story with prostate cancer. How is it that this even came on the grid for you?
Yeah, that's the question I get from these private conversations with men is how did you know? You don't know. The scariest thing about prostate cancer is it's asymptomatic inside the prostate. You're not going to feel anything. You're going to be out doing triathlons. You can be a 6 foot tall, 185 pound bodybuilder thinking you're the healthiest man in the world. You don't need to go to the doctor. And inside your prostate, you could be developing prostate cancer cells. Little tumors can be growing. You won't feel a thing. What you need is a PSA blood test. I'm sure we'll talk about that, and a digital rectal exam, so that the doctor can figure out if you're at risk for prostate cancer. And right now, the PSA test is the best way to find out if you have a suspicion for prostate cancer diagnosis in your prostate. But men, because they feel well, they don't feel anything, will not even go in and get the PSA test. And it's horrible to have cancer growing. You don't know it. So you've got to do the PSA test. And of course, the digital rectal exam. It's a combination of those two tests, with I think the PSA being the most important. The digital rectal exam is one that everybody hates, including the doctor in most cases, where the finger goes up the anus through the rectum, to push on the rectum, which sits right below the prostate, so they can feel the surface of the prostate. And what they're doing with that is they're feeling for size and smoothness. If they feel a lump or a bump, or they feel it harden more like a knuckle rather than the soft spot in the palm of your hand, they would say there's something suspicious going on in your prostate. However, to find a tumor on the wall of the prostate at early stages is very rare. So that's why the PSA test is more important. It's a combination, but I think it's more important. PSA test is prostate-specific antigen. It's a protein that's put out by cancer cells and the healthy cells within the prostate. The cancer in the prostate will cause that PSA to rise more rapidly and at a higher level. An enlarged prostate also will cause it to rise. So it could be an enlarged prostate or prostate cancer, and this is where the urologist comes in to try to diagnose which it is. There are a few other conditions like a prostatic infection or prostatitis, which is inflammation of the prostate, which could cause a rise in PSA. But what men have to watch out for is a high PSA could be prostate cancer. You need to get to a urologist to go through the various steps to get the diagnosis so you can get it out for the cure. And we could talk more about all of that medicine if you want to get into it.
Well, so right now, if I'm a man and I'm listening to this, I'm like, okay, Joe, so I don't know, 45 or maybe I'm 60. Like, when should me as a man be concerned about starting to get my PSA levels tested?
You know what, that's changing in the medical arena. It's more and more they're saying to start your first PSA test to get a baseline at age 40. Most doctors still today will say you don't even need a PSA test till you're 50. A lot of doctors will say you don't need a PSA test till you're 55. I say don't follow that advice. 55 is way too late. 50 is late. 40, you should at least get a baseline. It's just a simple blood draw. You asked about my case. In my case, I started getting PSA test around, I think it was around age 45. Or it was closer to 50, actually. And when I got my PSA test in 2019, it came in as a 4.2. Now, you got to remember, in 2019, I barely knew what the prostate was, much less what the PSA was. All I knew is when I saw that result on my blood test come in, it was considered to be a high normal on the blood test. But I thought, this seems high to me. And then I, in my own mind, I thought, I'm going to go look back in my portal, on my health portal, and look at last year's result. Last year's PSA result, 2018, was 2.75. My immediate instinct was I went from a 2.75 to 4.2. What is going on in my prostate?
Wait, Joe, you're telling me you were the one that was suspicious of a 4.2, so you decided to look into it? This wasn't coming from your doctor?
I got on it so fast, I can't say that my doctor didn't catch it, because I can tell you what his response was. Because the problem, I think my doctor probably even has a hard time with the fact that blood test results are sent to me at the same time they're sent to him. And he's a very busy man. And when I get an alert that my test results are in, I open them up. So I had the result probably even before he did. I called him and he said, yes, you're right. You should be concerned, but don't jump to conclusions. This could be nothing. It's still in the normal, right in the normal range. There are a lot of reasons your PSA can go up, but the next step is I'm sending you to a urologist. So he was right on that. But yes, I'm the one that called him, but that doesn't mean he didn't also catch it, because we were on it at the same time. We're a pretty good team. So.
I'm just wondering, I can't think of too many men that just out of the blue are going to be like, well, let me see if this PSA level is normal. Like, where was that awareness of, 4.2, even because you said it was in normal range?
Yeah, most of the stories I hear pretty much every day now, when people ask me about this, somebody will ask, and they'll say, well, what is your PSA level? The answer is always the same. They will say, it's normal. And I'll say, well, what's the number? They'll say, my doctor said it's normal, and I have a really good doctor. I said, can you go look up the number and then tell me what last year's number was? And then I'll be able to help you to determine what you should do next. So some will call back and some want to keep it private. But I will tell them if they call back, if they've got, I did have a friend, I've had a couple friends, one recently, unbelievably, said, yeah, mine was a 4.2. And I said, well, what was it last year? Well, my doctor's not worried about it. We're going to do another test. And I said, well, I'm glad your doctor's doing another PSA test. He goes, yeah, then he's going to do an MRI. And I said, okay, so this is good news. You have a doctor who's on it. But I still want to know, what was it last year? He said, well, it was a 2.0. So I'm thinking, I had just done this video and I said, you need to see this. I think what's in store for you is you're going to be doing a biopsy. It could be cancer, but I'm glad your doctor's on it. You're doing all the right things. But think of that. It was almost exactly like my case. And truly
Except a bigger gap.
I think people need to be concerned. And this number is getting doctors who are on this, urologists who are really heavily into the research, realize now that the concern should start in men at 2.5 PSA, this prostate specific antigen. That could be a concern that something is going on in the prostate. We should start eliminating things or watching this. Maybe get PSA tests not every year, but every 6 months to see how fast this number is moving up. What should we do next? That should be happening at 2.5 in all men. Right now, like I said, the lab value will come back as normal. On some lab results, it's 0 to 4.5, and it'll just come back to the doctor as normal, anywhere 0 to 4.5. Some of the labs have changed it to 0 to 4.0. So if you get a 4.0 or 4.2, they'll think, well, it's right around normal. That's kind of what happened to me. Interesting thing was, this should scare people about normal. I was diagnosed with a biopsy in 2019 with a prostate cancer in my prostate. After that 4.2, I went to the urologist and had the biopsy. I was diagnosed with prostate cancer. And we'll talk later about active surveillance and what all that means, but we decided to do a follow-up biopsy in 6 months rather than immediately go to surgery. It ended up that biopsy was 8 months later, but before the biopsy, which was supposed to be 6 months later, so in June of 2020, I had a PSA test, which was just standard before the biopsy. Let's do another PSA. I was a 4.43, not a 4.2. It had gone up to 4.43. The lab result came back. As I told you, I opened them up right away. Came back, 4.43, normal. Here I am, a man diagnosed by biopsy, by a pathologist. You have prostate cancer in your prostate. We're watching it. Blood study, PSA, says normal. So when your doctor says it's normal because it shows up on a range, you get these blood results and you look at them and your red blood cell count, your white blood cell count, all the stuff, normal, PSA, normal, everything's normal. Your doctor looks at it, closes the book, says you're fine, everything's normal. You look at it, you don't know what a PSA is, it says normal, you think it's fine. Guess what? It might not be. Mine said normal, and I had already been diagnosed with cancer. So just be careful on what the lab result says. Talk to your doctor. If you're above a 2.5, say, I'm concerned. Get your doctor on it. Your doctor will decide when you should go to a urologist, when are the next steps. Probably what your doctor will do is say, you're only a 2.5. That's still normal. It's more likely at 2.5 that you don't have cancer than that you do. But what you should do at 2.5 is be watching for increases. You should always be watching for a rapid increase. If that 2.5 goes to a 3 in 6 months or a year, or goes to a 3.2 or 3.5, that is most likely cancer growing inside the prostate. It's that rapid increase you've really got to look for. Mine went from 2.75 to 4.2 in 1 year. It was cancer. In hindsight, that meant the 2.75 was also cancer. Nobody would have suspected it at that level at that time in 2019, and probably would not have done a biopsy at that level. But maybe we would have done the PSA sooner rather than a year. But anyway, it can increase. It was increasing, obviously, over time. And if you see that rapid increase, something's going on, most likely cancer.
So if what I'm hearing, let me just kind of say it back to you. You can tell me if I'm hearing correctly. While it's important to know what your exact PSA level is, whether that's 2.75, 3.54, it doesn't mean as much without some sort of a baseline, because more important than the exact score is the relative difference between whatever the score was 6 months ago or a year ago to determine if it's gone from 3.25 and then in a year to 3.32 or something like that. okay, like gradual increases are actually within the realm of normal, but rapid increases is where all of a sudden it's like, oh, we need to invest or possibly need to investigate because that's where the red flag should show up. Why has it gone up a whole from 3 to 4 or 2.5 to 4?
That's exactly right. And I think that this rapid increase that could be, most likely could be prostate cancer, is prostate cancer, is something I think doctors, the urologists, are really starting to recognize. And I think the paradigm shift in urology will be to come up with a scale for the treating physician at the primary care level to look for in increases. In other words, get the message out. Start to be concerned at 2.5. If within 6 months it increases X amount, this could be cancer. If within a year it increases this amount, this could be, the follow-up steps that are needed. But they need a scale, and probably also a scale by age. The younger the man is, the more concerning for that increase, because prostate cancer in a young man, and by young I mean 40 to 50, the prostate cancer is typically, in most cases, more aggressive and harder to treat, and more important to get it treated early. And by treated early, I think in most cases prostatectomy to take the prostate out so that you have it cured, because that patient with metastatic disease in their 40s is one of the harder patients to treat in the prostate cancer arena for urologists to take care of that patient. They have a very aggressive cancer usually.
So if you find out that your PSA levels are increasing and you're like 70 years old, that is less of a concern than if you're 42.
If it's rapidly increasing at any age, it's concerning. You look at the 70-year-old man today climbing Kilimanjaro, playing tennis 3 times a week, doing triathlons, so there's the life expectancy is getting higher and higher. The active 70-year-olds are becoming larger and larger. The baby boom generation is still very active. They're not sedentary people. So this is very individualized for your treatment in your 70s, 75 and above, especially, to make a decision whether you're going to treat or let it go. The truth is that prostate cancer at older age, 75 into your 90s, is a much more slow growing cancer. So oftentimes, it could just be left alone in the prostate. It will not metastasize. You can live with it because it's more likely that something else would take your life before the prostate cancer would.
Which is where some of the misconceptions have come. That applies to all prostate cancer.
Exactly. And that those words should never be said to a man below the age of 60 or 60, even 65, probably 70. But that's the problem, is that thought transfers to younger men, and it should not. And the reason I think it does is the average age of diagnosis for prostate cancer is age 68. So most doctors are seeing patients with prostate cancer, 78, 80 years old, first diagnosed with prostate cancer. Like, that's where you get you can live with this, you're not going to die from it. Okay, maybe it makes sense to say that to an 83-year-old man. Never say that to some younger man, because you might have just killed that patient. The patient who's younger, and I'm putting young, I have a broad category of young. I'm going to be 65 this year, so I think I'm young. But 40 to 50, extremely aggressive and dire consequences if you don't treat it. Everything below 65, you really want to consider treatment, because it can be very aggressive. I mean, my friend who I described, he was 56, I think was his age when he died. So it can be very aggressive in a young man.
So Joe, take me back to your story. You call your doctor. You say, I think something's going. I looked at my last year's PSA. They were 2.75. This one's 4.2. He's like, Joe, you're right. What happens next?
He sent me to a urologist. I can't remember if we did. I think I just went straight to the urologist. There was not another PSA at that point, because I got there pretty quickly. And the urologist, when he saw the increase, he didn't say this to me, but I know this is why. He just sat down and started talking to me about cancer, which for as far as bedside manner goes, I thought he didn't give me any, he didn't give me any like lecture about, okay, you have a rising PSA. This could be an enlarged prostate. This could be, he didn't give me any other options. He just sat down and started talking about cancer. And I was a little disturbing. I thought, wow, I was kind of hoping I had an enlarged prostate, which is, benign and treatable condition. But he started talking about cancer, started talking about 5-year life expectancies and 10-year life expectancies. And what we're going to do next is do this biopsy, all scary stuff. And he was a nice guy and very competent, but it was a little bit alarming.
So this is like 0 to 60. You don't even.
In one visit. Yeah. Because when I went, my doctor said, don't be alarmed. This could be something else. Don't worry. Let's get you to a urologist. And I'm thinking, okay, I'm going to the urologist. He's going to tell me what else this could be. Because, of course, I'm thinking maybe it could be cancer. But he just started talking about it. It turns out he was right. I mean, I think he was just that smart that he was right. We did the biopsy and it was cancer. But yeah, that was a hard conversation. I'm sitting there, why are we talking about cancer? And then he had to back off. He goes, I'm not saying it is cancer. I'm saying we're going to test it for cancer. And here's what the test. They went through what the tests could be, how to prepare for it, and when we're going to do it, And we set the date. The first one was just a conversation about it. Then we set the date.
But I could just imagine, I bet this happens more often in medical situations where, a doctor that knows you is, I don't know if they're trying to soften it or if it's just their perspective. They're like, you know what? This is probably the expectation you can have. We're just going to explore things. You shouldn't be alarmed. Now, the specialist doesn't know that's the expectation that was set. They're just looking at data and wanting to be as, I don't know, accurate, representative, honest, whatever. And talk about misaligned expectations, right? You're thinking,
Right.
oh, he's going to come in and be like, yeah, so these are the 3 things that we think it might be. It's probably not going to be this, but we're going to. And all of a sudden he's talking 5-10 year life expectancy. That must have come out like a left hook. Like, what do you remember what you were feeling in that conversation?
Yeah, it wasn't a knockout punch, but it was a left hook that I was a little shaken for sure. I was like, why are we talking? I said to him, why are we talking about cancer? Are you saying I have cancer? No, I'm just saying what we're going to do to diagnose whether or not you have cancer.
So you felt comfortable asking him questions right away.
Yeah, I was definitely, I'm always not afraid to ask doctors a lot of questions. And I think for patients who we all trust our doctor. We all think, like I said, all men say, oh, my doctor told me it's normal. He's really smart. I'm thinking, there's no question. I'm not even questioning how smart your doctor is. But your doctor just said your PSA was normal, but you don't even know what the number is. So I think people don't ask the question. It's clear. Patients never ask their doctor, what was my PSA level? Most doctors don't tell their patient what their PSA level is. They just say it's normal. And so yeah, they can be really smart, but there's a gap in communication on specifics. So I think a patient has to be a self-advocate, knowing what I hope you learned today is your PSA number is very important. And if your doctor is going to tell you it's normal, say, what is my number and what was it last year? Ask your doctor that. Make your doctor look it up. If you don't know how to look it up, make him look it up while you're sitting there or talking to him on the phone or her and say, what was it last year? Because I need to know what has been my trend in PSA. They'll probably be surprised you're asking the question, wondering why you're asking the question, but you might even catch the doctor saying, oh, yeah, maybe we should do something about this because they're just seeing normal and then move on.
So at this point in time, when you're sitting there with the urologist, what do you know about the prostate and prostate cancer?
Nothing. I knew nothing. Again, I barely knew what the prostate was when I was told I was going to a urologist. He explained a lot to me about with the biopsy, about some things that would occur, which gave me some idea of the anatomy and a little bit about what it does. I still didn't really understand what it did. So I started at that time when I was told that I had to do a biopsy, started doing my own research, getting online and what is a biopsy, what does it entail? And so my learning process started the minute I got diagnosed with prostate cancer. I started digging deep into it. And as it went on over the last many years, I've dug way into the weeds on prostate cancer.
Okay, so tell me.
The medical research.
The urologist says, we need to get a biopsy. So from that appointment to biopsy to diagnosis, what time period are we looking at?
The diagnosis came in because I remember where I was sitting when I got the call after the biopsy results came in was in October of 2019. So it was within a month. I mean, I was September, it was the 4.2. Then by the late October, I had the result from the biopsy. There was a time period between the 4.2, the meeting with the urologist, the setting of the biopsy, going in for the biopsy, and then getting the result. But the result came in. So I would say about a 1 month. We're talking about a 1 month period, which is pretty fast in medicine these days to be able to get that kind of results.
And you're hearing about it from your GP or from the urologist?
GP. My GP called me. He called me. I was actually down in Mexico on a little trip. My phone rang. I looked at it. I saw it was from my doctor. I stepped away from the restaurant. I said, I got to go take this call. I was out on the street in Mexico, and he goes, Joe, you've got cancer. Sorry to tell you, but again, he said but it's a low-risk cancer. So it's cancer, but it's something that I think you're going to be okay. You're going to go back to the urologist, talk about next steps, but don't worry about it. Prostate cancer typically moves slow. People live their normal life expectancy with it. You're going to be okay. Don't be as alarmed. I know when you hear the word cancer, you're alarmed. Don't be alarmed. So he's very calming. And so I remained calm. He's a very good doctor. As it turned out, it was more aggressive than we all thought.
So at that point, is that when he first mentioned Gleason 6? Like, that term, was that thrown around yet?
I can't remember if he did. My urologist explained that to me. And if you ask me to explain it to this day, I can't. All I can tell you, I have a really hard time, as much as I've read about Gleason scores. At the time I was diagnosed, was a Gleason 6. You can either be Gleason 6, Gleason 7, 8, 9, or 10. Gleason 6 is the most low-risk, indolent form of prostate cancer, kind of classified as non-aggressive, slow-moving cancer. This is the type cancer, Gleason 6. If an 80-year-old man gets diagnosed with that, or 84-year-old man gets diagnosed with that, it likely will just sit there in their prostate, Gleason 6, until they die. But in a younger man, if you're in your 40s, that thing might jump quickly. I'm 58 when I get the diagnosis. I'll tell you about this decision with the active surveillance. So when I talked to my urologist, he told me what I just said about Gleason 6. This is a low risk. This can sit there in your prostate for a long time before you ever need surgery. And avoiding surgery is something people, he's talking generally. He's trying to let me make the decision that people want to do, because who would want to do surgery? The risk of surgery is erectile dysfunction, urinary incontinence, although I can tell you the stats on that have improved tremendously. It's rare. It's more rare now than it used to be. 100%. Now it's very rare that you're going to have erectile dysfunction and urinary incontinence, and maybe not as severe as it used to be total. Everything's improved with the surgery, and he explained that. He didn't give me all the details, but he said, so it's improved, but those are still risks. And he said, but with Gleason 6, he said, you can live for a long time with that in your prostate. And I've seen men live with it for years, 5 to 10 years. So can this surgery put off a year? For sure. Maybe even 2, maybe even 5 years. So this is all music to my ears that this thing could be put off. He said, so you are a candidate for what we call, some call it watchful waiting, but it's called active surveillance. And so I said, what is that? And he explained it. And patients will now hear this, and I'm going to tell you that something I would be cautious about. But the active surveillance means that they're going to follow up with a biopsy 6 months after the one you just had that showed you had cancer. We're going to do another one in 6 months to see if it's still, the Gleason 6. And then they'll do another one maybe a year after that, but they'll keep watching the PSA. So between the PSA and then these serial biopsies, they'll determine whether the cancer is becoming more aggressive and you need to either treat it with radiation or a prostatectomy to remove the prostate. So that's what we did. I selected active surveillance because like I said, you're singing my song. I don't have to do surgery. I don't have to incur these risks. Erectile
Unnecessarily.
dysfunction or incontinence, of course. If you're saying that it's even possible I could wait 5 years, and then I could do this when I'm closer to 65 than I am now at 58, 50, 59. I think by the time I had that conversation, I was 59. I would like to put that off. So I did. And then what happened was, I think we just talked about that the PSA had gone up, came back as normal. We talked about that part. Then on June 8th, when I was supposed to have the second biopsy, now we are in the throes of COVID. This is June of 2020. So you're not even really allowed to go in the hospital unless you have a necessary procedure. There's no elective procedures going on. So I got a call on June 8th of 2020 from his office saying he's in a surgery. He got held up. We're going to have to reschedule. I tried to reschedule. I was available. It's COVID. I'm like, I'm not even going to the office. So whatever day you want to do it, I can do it. Rescheduled for August 6th. Went back and had the biopsy in August of 2020, and it came back as Gleason 7, which is now intermediate risk. The call from the urologist after that biopsy was, it's decision time. It's my recommendation you do a prostatectomy. We'll do it in 60 days because right after a biopsy, we always have to wait 60 days because your prostate's so inflamed, bleeding. It's, something we wouldn't operate on for at least 60 days till it calms down. So you've got 60 days to make a decision, but the sooner the better because I got to get you on the schedule. But you got to make a decision between radiation treatment or surgical treatment, removal, as soon as possible, and we'll get you on the schedule if you choose prostatectomy, which is what I'm recommending. That was the conversation.
So what do you do right then? Like, are you thinking like, are you straight to research? Are you straight to like looking at reviews? You're trying to figure out an incredibly important decision.
Mm-hmm.
And obviously you have the suggestion that the urologist made, but at the same time, it's like a surgery is a surgery, right? There's always complications. There's, negative side effects. Was a part of you ever leaning toward radiation?
What I did next was, again, my primary care physician is a very good friend, and a great guy, and really brilliant doctor. So I immediately went to him to help me with this decision. And he agreed, obviously, that those are the two options. And he had a really good friend that he went to medical school with who's in the radiation oncology field. And he said, this guy's brilliant. He's taking care of prostate cancer patients with radiation therapy. So he sent me to him. And he was right. That doctor was really good bedside manner, really good at explaining things. Almost had me talked into doing radiation, which was through he talked a little bit about cryotherapy, but his technique was brachytherapy, which is these radioactive seeds that they put into the prostate to control and kill cancer cells in the prostate, to keep it under control. If there's any evidence that the cancer is getting out, then they have to go to external beam radiation to try to get it in the area. But now you're, I think, more in trouble. So I didn't like that part where there's radiation and possibility of radiation on top of radiation. But he did talk about, the high maintenance of erectile function, less urinary incontinence than men used to have in prior treatment. So he was very convincing about what a normal life I would have. And I started leaning toward it until a few days later. Actually, I talked to that friend, the one who died, who said he was pretty blunt. He was, just take it out. Just take it out, which has become my mantra now. And he kind of convinced me. I was back on it, and I made the decision. I would rather have the cancer and the cancer-containing vessel out of my body so I don't have to ever think about it again. I mean, when you think about prostate cancer, within this walnut-shaped gland that's sitting in your body, it's in a neat little package. And if you can just remove that little box full of cancer, take it out of your body, and be cancer-free from prostate cancer the rest of your life, I liked that thought. I was like, yeah, I just want to do that. The risk of incontinence and erectile dysfunction, I'm not going to worry about it. I'm just going to take it out.
Yeah, I can understand even just the psychological relief of knowing that you don't have cancer in your body. So now all of a sudden, fast forward, it's August. Your biopsy got delayed,
Mhm.
or was it?
August was the second biopsy. So now I'm in that period of 60 days waiting, to make the decision. And I made the decision somewhere in early September, a couple of weeks after I talked to the doctor from the August 6th biopsy. I went out and met with that radiation oncologist, and then I called him in early to mid-September. It was closer to early September, and so I made a decision. We're going to take it out. So I want to get on your October schedule. The October schedule is full. Again, we're still in the throes of COVID. Surgeons were limited on how many surgeries they could do, how much time could be spent in the hospital, how many people had to come in only for surgeries that were necessary. Again, no electives. So yes, prostatectomy was not considered elective. You're dealing with a guy cancer surgery, so it's high priority surgery, but the operating rooms were not at full capacity. So he had to find an operating room that was going to be open in October that had available time. There were 3 hospitals in the system. We found the one that had the early date, November 6, 2020. That's when I had the surgery.
Okay. So I think it's crazy that this whole thing's happening in COVID because, right, during your visits, even with the surgery, like, is your wife able to come with you?
She couldn't come on any visits. We did, starting everything after March of 2020, all visits were Zoom calls with my urologist. Obviously, the biopsy was it's an office, it's an outpatient procedure in his office. So I would go there, but she couldn't come with me. It's not allowed in a hospital or the office. Only the patient could go. For my surgery on November 6th, she dropped me off at the front door of the hospital, not allowed to come in. She would have liked to have been there in the waiting room outside of the operating room so if anything happened, the doctor could tell her. I think that's what happens in most surgery, but she couldn't be there. She was at home.
I know some men struggle having to tell their significant other or their spouse that they have prostate cancer. There's just something about it. I don't know if acknowledging something that could make them feel vulnerable or weak. Not to go too far back, but when you were in Mexico and you heard from your doctor it's cancer, was that an easy conversation for you to have with your wife? Was it something that you put off, or was it something that was just kind of natural? This is it.
That's definitely highly individualized. You're talking about me specifically. My wife is a glass half full person. Everything's always going to be okay, no matter how horrible any situation is. I mean, she's a real estate agent. I've seen her where deals are blowing up, and she is as calm as can be. Everything's going to work out, and it usually does because of the way she operates. So her mindset is everything's going to be okay. So in a way, she's as calming as my primary care physician. So she was a good team member in all of this because she was always, everything's going to be okay. We're going to get through this. The hard conversation, I think, for men, because you don't even want to talk about it with your wife, is there's a chance I may get ED, permanent ED. There's a chance I may be wearing diapers for the rest of my life. And to have your wife say, that doesn't matter. I want you to be alive. That's what's most important. You think, God, I hope that's true. But, that's the conversation that men are afraid to have. And I understand why. I mean, for our manhood, being able to have sexual intercourse, have an erection is a big, huge part of our manhood. And the fear of losing that is something you don't certainly want to talk about with friends, but not even with your wife, because you're afraid, what's her reaction going to be if I tell her this is it? Could be it. I mean, at that point, you don't know anything, but it could be because the doctors are telling you it could be permanent. But in most cases now, erectile dysfunction is definitely going to happen post prostatectomy. No question. 12 to 18 months, sometimes even 2 years. 12 to 18 months is normal and it's expected. Certainly most women can deal with that. I bet you a lot of men will tell you, well, 12 months, that seems to be about normal anyway, but about it when we're going to have sex. But 12 to 18 months without an erection for sure. And then after it, in a prostatectomy now, the way they're doing them, the success rate for maintaining the erectile nerves is so high that it's as high in some cases. If they spare both nerves very successfully, they'll have like a 97% possibility of an erection after prostatectomy. If one nerve is injured, it can lower to like 75 to 80%. You'll still be able to have an erection. Now, with only one nerve, that erection probably won't be as strong. Even with the two nerves being spared, it might not be as strong. But guess what? We have a drug that's been invented, put on the market many years ago, this Cialis, Viagra, sildenafil, and the one that is great because it's cheap is tadalafil, which is the generic for Cialis. And so men, I can tell men right now that post-prostatectomy, you're going to be on those drugs. So get over it. It's something you're going to need, and you should just pop it right in front of your wife and go, I'm taking my daily Cialis. It's to help your penile health, get blood flow to your penis, keep those tissues healthy. If you want to have erections, you should be on that drug.
So, Joe, as men are reaching out to you and they're talking openly, is it something that you can tell they're reluctant to talk about when it comes to like treatment options? And do they kind of skirt around the whole ED?
Yeah.
Do they know about it? Like, how are they in their comfort discussing that?
It's interesting. I'm an attorney, and they literally declare attorney-client privilege with me. They'll say, I want to talk to you about this, but this goes nowhere. Nobody. I mean, I'm not kidding. That's mostly how the conversation begins. They don't want anybody to know that they have prostate cancer or that they fear these things that we're talking about. So, yeah, I have a very open conversation with them, much like I'm having with you right now about everything that's going to happen.
So this is the first time you've mentioned that you're an attorney. In what ways did that actually help prepare you for this experience with prostate cancer? Because people may not know, you're not just any sort of attorney. What is your specific background with that?
I'm a trial attorney, and I've been since 1988. What's that? For 37 years now in the personal injury trial practice business, which means that every day of my life as an attorney, I'm dealing with medical issues. I'm either reviewing medical records to interpret medical records by talking to the doctors who wrote the records, taking depositions of doctors, experts. And before I would take depositions of doctors, I would do medical research, dig deep into medical research so that when I'm asking questions of them, I can ask intelligent questions with them and converse in their language about the medical issues and also not have the wool pulled over my eyes. They're trying to tell me something that is absolutely not what is contained in the medical literature or in the medical record. You're trying to trick me here, doctor. The medical record says the opposite of what you just said. You have to point it out to them. So yes, I have to dig deep in my profession into medical issues. So how did that help me in this? When I needed to learn, like I said, I didn't know anything about the prostate or prostate cancer or
Wait, so
anything.
just to pause you there.
I
So
had
that
to dig in.
That means in 37 years of you doing this, there was not a case where you actually had to research the prostate.
No, I didn't ever. I never had a case that had anything to do with the prostate. Nothing. The closest thing I had to a prostate case would be a urinary tract infection issue. That's about the closest. So I knew what the urethra was. That's about it. Yeah.
But it equipped you because not only were you very competent in having to understand medical terms, but you also didn't have any issues questioning medical professionals.
No, yeah, that and also digging into research that's highly medical because it's something I did every day. I guess it'd be the equivalent of somebody who's bilingual. It's like I don't have any problem that this person I'm talking to only speaks Spanish because I'm bilingual. That's kind of the way you get in the personal injury field is you're just dealing with medicine all the time. So you can talk the language, you can learn. If you're good at it, that's what you're doing. You're learning the language of medicine. You're learning how to learn what you don't know, how to do good research, how to talk to experts in a way so you can learn from them. They're in your case. They're become witnesses. So learn everything about it from your own expert on your side of the case so that you can challenge the expert on the other side of the case. And it's a profession that requires you to learn medicine. So yes, I was in a comfortable area learning something I didn't know at the beginning.
And I know we're going to get to that soon, where there was an experience with a medical professional where because of your research, you were able to understand that they weren't the right person to provide medical care for you, where a normal patient that doesn't have such extensive research may have just been forced to trust them. But let's get back to your story with the surgery and what happens. Tell me about what they were preparing you for as far as expectations with the surgery, and just take it from there.
I don't know when. I probably did have this in my mind at some point, but at some point along the way, pretty recently, there's a new surgical technique that they can do laparoscopically with a Da Vinci robot. And these urologists, especially the younger urologists, but by that I mean the men and women in their 40s and above, 40s to now, the older doctors, guys like my age in their 60s, have also learned this, but the ones in their 40s, this is all they've learned, the 40s and 50s. So they're like just getting expert at operating this robot and doing this surgery, which is less invasive because it's only 4 holes in the abdomen and then the incision in the umbilical to pull it out. They go in with their probes, they work the arms of this robot. They're able to spare the nerve much better than they were able to do it in an open procedure. There's less scar tissue. Everything about it is more precision and less side effects. So that's what I had. I had the Da Vinci robot and a doctor who was very good at it, had a good record at it. And so that's what I had. He told me how good he was at it. Surgeons like to talk about how good they are at something.
Which feels good as a patient to know.
Feels
this isn't
really
your
good.
First rodeo.
Feels really good. And he was highly recommended, and he is good at it. It's just that I was maybe not the best patient, as it turned out, intraoperatively, because when he got in there, one of the nerves, the control of the erection, was stuck to the prostate. So he said, I had a really hard time lifting that nerve. It was really stuck. So he said, I think that nerve is damaged and probably won't recover. This is him telling me afterwards. He goes, the other nerve lifted right off. That one I spared. That's going to be a functioning nerve. You're fine. Then he said, and you just kept bleeding. I don't know why. I've never seen it like this. He goes, I was in there with you for like 5.5 hours. It was supposed to be a 2.5-hour surgery. And I said I couldn't stop the bleeding. I was constantly cauterizing bleeders. You just kept bleeding. The other thing he said, I'm still coming out of anesthesia hearing all this. I'm wondering if I'm in a nightmare. Then he said,
and you're by yourself. Your wife's not with you.
Right. She's not hearing any of this. She's at home. And I don't even report it to her because I couldn't talk on the phone. I was still post-operative and a little bit groggy. But he said, and there was a lymph node that had a tumor. So when I saw that, I took out extra lymph nodes. I took out 19 lymph nodes. So they would be sent to the lab with the prostate to analyze nearby lymph nodes to see if there was cancer in the lymph nodes. I'm sure he suspected it was cancer, but at that moment he didn't have a pathological diagnosis of it yet. He's not going to tell me, I found a cancerous tumor in your lymph node, but I know that's what he was thinking it was.
Oh, I see, because it could have been benign.
Could have been, yeah, just a benign cyst of some sort.
It just happened to be right next to
which happens. That happens in the lymphatic systems full of fluids. Cysts can form. It could have just been a little lump or cyst, but I'm sure he thought it was a cancerous tumor, but he wasn't going to say that at that moment. He said he sent it all to the lab. We'll wait for the lab results to come in. So I was at the hospital, recover. You're there for one night. Just sleep that night and get up the next day and checked out the next afternoon. My wife was they allowed her to come in to pick me up, which was very nice. So that was about the only time she got to come into the hospital.
So when did they then let you know the lab results? What was this, like a week or two waiting?
Yeah, it was.
And what was this like for you? Like
it was within a week. It was within a week.
When you heard that, what were you thinking?
So when I got that when I heard from him, I was thinking this lymph node is probably metastatic cancer. I was thinking that too, because again, by this time I had done enough research. And one of the places, the reason they take lymph nodes, you only read about it. They talk about that they will take lymph nodes during the procedure. Why do they take lymph nodes? Because it's the most common place that any cancer that gets out will go.
Because the lymph
It's
actually
very close.
but it's also meant to try to purify.
I'm not exactly sure why.
Okay.
Now you're getting. Now you're going to have to talk to the urologist.
I think that's part of the function of the lymph. So that's why it's not uncommon for it to absorb toxins or things that are abnormal.
So
not medical advice.
I just knew, because I had read the reason they're taking lymph nodes is to look for nearby, metastasis from the prostate, because that's one place that it typically goes and can be found during surgery. I mean, if it went to some other organ or something, they're not going to start probing organs and looking for it. But the lymph node, they can just pull them out. So they always take a few, usually like 10 or 12. This time he took 19. So I was worried at that point, but I waited for the result. And the result came back that the lymph node was positive for prostate cancer, and also that there was a margin on the prostate, which makes sense because we have a metastatic lymph node. Margin means that there's like a crack in the wall of the prostate. That's not a medical term, crack. I think it's like fissure, or I can't exactly remember what it said on the pathology, but there's a small opening of the prostate. It only takes a small opening. The prostate wall is very thin, and if a tumor pushes on it, can push just hard enough to crack the wall of the prostate. And what happens then is millions of cancer cells get out into the body. Now you've got metastatic disease. So the question is, where are those cells going? If you think of it like an ocean and all this stuff just gets dumped into the water, where are they going to swim? I mean, you just think of millions of cancer cells now in your body. Where are they going to go? Most often they'll congregate very nearby in the pelvic floor. Unfortunately, they also will go to the bone, mostly in the legs. So sometimes they find it has metastasized to the bone, which is a bad prognosis. You don't want that. But so it's scary. They told me you had a margin, you had a positive for cancer in the lymph node, only the one. The other 18 were clear, which is good. Again, now they're hedging everything. We can't say that it didn't go into the lymphatic system, but we can say that 18 were clear and it's only one. So, of course, I had asked the question, so what's the chances that my cancer got out and the only tumor ever formed or is going to form is in that lymph node and now we've cured it? He goes, no, I don't think so. I knew the answer, but I just thought I would ask it anyway. But he said, you've got metastatic disease. And then he said, so what's going to happen next? This was now, I'm at home, out of the operating room. This is another Zoom call. He said, so what's going to happen next is you will no longer be my patient because I'm urology. Now it's time to turn you over to oncology. You're an oncology patient now. And I will be here to answer any questions, but I'll give you names of 2 oncologists at our hospital that I'm going to recommend. And you can talk to your primary care and see what he thinks. And which I did. And we picked an oncologist and I went for next stop, oncology.
How are you feeling in this moment? Because it just seems like it's progressing. You're going from a general practitioner to all of a sudden now a specialist to a urologist to all of a sudden now the cancer doctor, the oncologist.
Yeah, now life expectancy talk became more dim. Change your life expectancy. 5-year life expectancy after a prostatectomy, especially with successful removal and no margin, they'll only put it at 99% because they don't want to say 100%. I think it's truly 100%. If you can get that package, that prostate out, with that cancer all contained in the prostate, you are cured. That's curable prostate cancer. That's a success story, right? Once it gets out, it could go anywhere in your body and affect organs or your bone, and you can die from this. And this is where, your mind changes to, okay, I've got to now get the best treatment for my metastatic disease to make sure I live as long. I want to beat the 10-year life expectancy and live my normal life. Who wouldn't, right? So that was my mindset. And talk about digging into the medical research. Now I'm going deep dive into the various treatments and what we're going to do.
Okay, so this might be a really dumb question. I just have to preface that. There's no chance that like the biopsy is related to the margin on the prostate. as to why there was like leakage or escape.
That the biopsy actually caused the margin.
Yeah.
I've seen doctors out there that say, don't do a biopsy because it can cause the margin. That's just, no, they're putting such a small, that needle that they do the biopsy is so thin.
Okay.
They pull it in and pull it out. That hole is so small, it'll heal almost immediately in the wall. That would just be the craziest thing ever that caused it.
Okay.
The more likely thing is the pressure from the tumor or tumors that are building up and causing pressure on the wall, which is very thin to the point it finally cracks. If you think of it like almost like a paper, it's paper thin, and you just push on it with the slightest little pressure, it can crack it. But this little hole from the needle from the biopsy is not going to cause a margin. I'm going way out on a limb here. I'm not a doctor, but
that sounds right.
I've heard doctors say, well, the reason you don't want to biopsy, there could be a risk that cancer will be released. Well, I think I don't understand any literature that supports that.
So tell me, now all of a sudden you're getting recommended to an oncologist, and the beginning conversations with that oncologist are what?
The treatment was recommended was ADT, which is called androgen deprivation therapy, which means androgen is your testosterone.
And is this at Mayo?
This now is locally. I'm in the north suburbs of Chicago, so this is at my sort of local hospital system. Okay. Androgen deprivation therapy, which is the androgen is testosterone, and deprivation means they're going to take away your testosterone. It's therapeutic. Very beautiful words for what they used to call chemical castration. What it is chemical castration. At one time, they used to do an orchiectomy. That's a fancy word for castration, chopping off the testicles to control. Way back in the day, prostate cancer, they would just chop off the testicles to put the cancer under control. The reason that they want to remove testosterone is prostate cancer cells feed on testosterone, causes them to grow, to remain active, to mutate, to divide. Everything that they do, all the life of a cancer cell is enhanced with testosterone. It's like that's what it feeds on. You think of like a Pac-Man, love to feed on testosterone apparently. So they want to take the testosterone away, which doesn't kill the cancer cells, but it basically slows them down and puts them to sleep in what they call senescence. They just slow down. They stop reproducing and dividing, etc. And then on top of that, the next thing to do is radiation. So if you think about it, if they're able to put these cancer cells asleep, and they assume they're in the pelvic floor or they're surrounding where the tumor is, if they're able to find a tumor, they know there's going to be cancer cells around that. So the best case scenario is to find the tumor and know that there are cancer cells around it and radiate the tumor and the surrounding area. And that's what the treatment was. It was recommended for me was to do radiation and ADT.
Now, did we miss the part about the provider that you didn't agree with?
Yes.
Okay.
So the oncologist sent me to his radiation oncologist or radiation therapist who does the radiation treatment. And a very nice older man who obviously has had a very successful career in this. But as he started talking to me, I thought, I like him. There's nothing against him. I'm genuinely one of the kindest Marcus Welby type doctors I ever met. Because okay, you start drawing a field, a little circle. He goes, here's where your prostate was, but we're going to do this area. We're going to radiate. And I said, well, so now how do you know that the tumor's within that circle you just drew? He goes, oh no, we don't know where the tumor is. I said, well, so you're going to radiate without knowing where the tumor is? Why would you do that? He goes, well, we think that's where it is. So I was immediately uncomfortable. And then he started saying, look, this is what he said to me. He goes, look, if your doctor who did the surgery knew when he found that lymph node, if he suspected that was cancer, he would have closed you up and not even taken out the prostate. You realize that. You would just be, living with this disease. And I'm thinking, this is exactly what they did in 70s and 80s, big open procedure. They'd go in, they saw a bunch of tumors in the lymph nodes. They would say, can't save them, close them up. They don't do that anymore. They take the prostate out and start treating the metastatic disease with high success for extending life. And even, for long periods, some men, their life with metastasis is the total life expectancy. Now, obviously, like I said, we lose 35,000 men a year, so not everybody makes it, but there's a high success rate in treatment. So he was talking about back in the day, and he was practicing then, I'm sure, but I thought, wrong guy. I was so uncomfortable, so I left, and I said, we're not doing this. Then I went on to the next phase.
Well, I think that's so interesting because only because of the way you educated yourself, because of you being comfortable with the medical literature, understanding breaking down some of these things, I don't know if you hadn't done that, if you would have recognized this guy's talking, his frame of reference is as if we're still operating 30 years ago. So therefore, I don't know if I should trust his method now of treatment. So I don't know. I just think
I felt like I was in almost more of a factory. This is what we've been doing for 30 years. This is what we're going to do for you. And meanwhile, I'm having surgery with the guy using the most highly skilled robot surgery there is. There are multiple doctors still do the open procedure, which this doctor was talking about. He didn't even know I didn't have an open procedure. He's talking about an open procedure. He didn't even know I had the Da Vinci robot. I'm thinking he hasn't even looked at my medical records. He's talking about something from the 70s and the 80s. And when the doctor found that lymph node, when he cut it out, he didn't say, let's stop the surgery. In fact, he found it I don't know which came first, pulling the lymph nodes out of the prostate out, but probably the prostate had already been out when he started snipping lymph nodes. So it's just not the way it's done. So I felt uncomfortable that this is a guy who just tells the same story to every patient who comes in and just has been doing the same thing. And by the way, that pelvic floor radiation probably does catch a lot of cancers, because it is true that most often the cancer cells and the tumor are in the pelvic floor. That's true. But it's also there's a high percentage that get outside of the pelvic floor and form somewhere else. And I've got stories on that too. But
so when did you become aware of PSMA and the PSMA scan?
Okay, so PSMA is a amazing newly found technique in both diagnosis and treatment of metastatic disease. PSMA stands for the prostate specific membrane antigen. On a prostate cell, and a prostate cancer cell, they have membrane, and some of the membranes are the membranes are called the prostate specific membrane, and they have this ability to hold a radioactive nuclide, so that on a scan, which they developed called a PSMA scan, and they use a gallium as the most often used nuclide. They'll inject that into your bloodstream, and the gallium will go and find prostate cancer tumors and sit on the wall, and it'll light up on the scan. So they can find tumors more easily on this PSMA scan. Where I found out about the PSMA scan was through research. I'm researching PSA, and PSMA comes up, and PSMA scan. I thought, I don't know what this is. And it was new. It was something that was being worked on in the mid 2008, like 2015 to 2020. It just came out. And I think 2020 or 2019. Now remember, now we're at the point where I'm into 2021. This thing is new. It's only at 3 hospitals in the country. One of them's University of California, San Francisco. One of them is UCLA. I wish I could remember the third, but I don't. I called University of California, San Francisco, and talked to their PSMA radiology department. And there was a very nice, nurse administrator that talked to me. I told her my situation, and she said, yes, you would be a candidate for a PSMA scan. But what you have to do is, we are not taking any patients until their PSA reaches a 0.5. So when you reach a zero point 0.5, call us back. We'll get you on the schedule. You can fly out here for your PSMA scan, but insurance won't cover it. I said, oh, how much does it cost? She said $5,000. So I said, you know what? I'm going to do this because that was a way to, the earliest way available today to find a tumor at its earliest, smallest size is the PSMA scan. And so I wanted to do it. And so that was the plan. I was getting ready to wait till I went to a PSA of 0.5, and I was going to go out to San Francisco. Now, some of the listeners will be like, okay, your prostate's come out. Prostate is where PSA comes from. You already explained that earlier. Why would you have PSA? Why would you have PSA in your blood if your prostate's gone? You've already had your prostate removed. Because it's the prostate cancer cells that are in your body are still putting out PSA, prostate-specific antigen. So you're still going to, PSA is going to leak into the bloodstream and be picked up on a PSA test. So mine did start to grow back slowly on blood. I mean, the PSA level started to increase slowly in the blood test. I didn't get to, well, I got to tell the rest of the story about why it got to a 0.2, 0.3, but it would have taken a while to get to a 0.5 is the point. It was kind of a slow increase in PSA, even though.
So it almost reset though.
And I had not done the shot yet for the androgen deprivation therapy. Remember, and I have to talk about a story I had with another doctor as to why I waited. So you can go ahead and ask questions.
I was just going to say, so it was at 4.2. You get the surgery. At some point, it's because the prostate's removed, it's not 4.2 anymore.
Yeah.
But it still registers as something. Do you know what?
So the prostate is out.
Yeah.
And that tumor, which is the main tumor, it's called are tumors, but they found one, I can't remember the exact size, but they found one pretty significant tumor in that prostate. That's gone. That's out of my body. That's one you hope to get that's contained. And they say, congratulations, you're cured. That was in there and that's gone. So the PSA coming out of the prostate is gone. So now it's just prostate cancer cells, which are these new cells that are out there growing. And so they're starting to kick off PSA.
Do you have a new baseline at this time? Like, did they given you a...
I'm trying to remember when I had it. Yeah, you do get a new baseline. I'm just trying to remember at what stage I got the next PSA test after surgery. But it was pretty soon after surgery. They did it a couple months after.
And do you remember what that was?
The very beginning, it was like a 0.06 or 9. But it was there.
Okay.
So, it's like,
so the idea
question,
of waiting to 0.5.
I kind of in my own mind had the same thing. Why would I even have this PSA? Then I realized, I think through a question or just through logic, that it was the cancer cells, but that was confirmed that the cancer cells outside of the prostate also put off PSA. So after my call with University of California, San Francisco, I talked to, there's more to this story, but I talked to Dr. Eugene Kwan at Mayo Clinic, who's the director of prostate cancer research and one of the top, if not the top in the United States. Of course, doctors would argue about who's the best, but he's one of the top in the world for prostate cancer. And I had a friend who I won't name, but I just kind of refer to him, even to his face, as my guardian angel. Because when he heard my story about decisions I was trying to make and stuff, all the way through, another friend put him on to me. I didn't even know he had prostate cancer. I know him, but I had no idea he had prostate cancer. And we talked, and he was kind of guiding me through everything post-prostatectomy. And when he kind of heard my story, he told me his story. And his story was that when he had his prostate cancer was found metastasized postoperatively, they found it had metastasized. They put him on ADT, and then they took him off ADT, and I forgot about it. They put him on ADT. I don't want to forget the most important part. And they radiated the pelvic floor. Sound familiar? Same thing was being recommended to me, right? So then he stayed on the ADT, and then I don't know if he was on for 18 months or 2 years. I don't remember that part. But when he went off, his PSA started to rise, which it shouldn't if they got the cancer, right? So that means there's still cancer out there somewhere. So they're treatment at that time was, let's put you back on ADT. So they put him back on, and they were doing what they were calling intermittent ADT treatment to see if they could control the cancer. And then they'll take you off because they don't want you to be on ADT too long because it's bad for you. So they take him off. And then the PSA would rise again, and they'd put him back on. This went on for almost 10 years. And finally he found Dr. Kwan, however he found him. He went up to Mayo Clinic, and Dr. Kwan came into me, did a choline PET scan. They didn't have PSMA scan at the time. And he was doing these things called a choline PET scan. I can't tell you what choline is, but it was another way that prostate cancer is more easily found on the PET scan with choline. He's still doing those, actually. So he said, the reason your PSA keeps going up, because you didn't have a tumor in your pelvic floor. Your tumor is in your back. Tumor number 1's in your back. Tumor number 2's in your abdomen, your abdominal wall. So we're going to treat those tumors. And he is still a metastatic cancer patient, but, this whole scenario being on intermittent ADT has ended. He's had chemo and other things to treat his metastatic disease, but as it turns out, that whole pelvic floor radiation for him was unnecessary and did nothing except expose him to unnecessary radiation. It did nothing for his cancer. Hearing that story and hearing my story of what I had conversation with, or not even that conversation, but what I was going about to do, was to go have a conversation with Oncology. He said, I'm going to have you meet my doctor, Dr. Kwan. And I had not talked to Dr. Kwan before my oncology radiology, this visit. But the day that I called University of California, San Francisco, which was when I got home from having that conversation with this doctor who told me we're going to radiate the pelvic floor, we don't know where the tumor is, Dr. Kwan called me because my friend asked him to, because he's treated him so much, they've, I guess, become friendly enough that he would call me. He's a extremely busy doctor. To get a call from him is very unusual, but was very kind. And he said to me, yeah, I know what they told you. I know what they told you. You don't have to tell me. I hear it. Every patient that comes up here with a similar story, I bet you they told you they're going to radiate the pelvic floor. They're going to put you on ADT, and either you asked them or they told you that they have no idea where the tumor is. I go, that's exactly what happened. He goes, yeah, you're not going to do that. Here's what we're going to do. He goes, I won't treat a tumor till I know where the tumor is. And I thought, okay, I like the way this guy's talking already. And then he said, so what I would do is we'll scan you to find the tumor, then we'll treat it with ADT and radiation. I said, well, I just got off the phone with University of California, San Francisco about this PSMA scan. I go, I know you must be familiar with that, of course. And he goes, not only am I familiar with it, we're going to be the 4th hospital in the country to get it, and we're getting it within the next couple of weeks. He goes, and I'm going to do a clinical study on PSMA scan to see if we can find it earlier than what they're doing in California. He said, they're testing at 0.5. I'm going to test at 0.25 PSA. And I said, so you think you can find it at less than 0.5? He said, I don't know, but we're going to find out. And he goes, in fact, you'll be one of my early guinea pigs because I'm going to start this clinical study when it gets approved, and we're going to have the scan in the next couple of weeks. So what you have to do is wait for your PSA to grow to a 0.25, and then you'll come up here to Rochester, Minnesota, and we'll put you on the PSMA scan and see if we can find the tumor. And so that's what I did. I waited and watched.
What was that time period? So from when you were 0.06 to 0.25, was that a few months?
It was in the fall, around November of now 2021. Or maybe it was
Are you
October.
getting tests every month, every 3 months? What's the frequency?
Yes, it was every 3 months. But when it finally got to 0.21, which was really close to a 0.25. So we did one a little sooner after that one because I only needed to get to a 0.25. So I can't remember if we did it a month later or whatever, because it was 0.21. We decided, let's get it another one, because all I needed to get into a study was a 0.25. And then I needed 2 results at 0.25 or higher. So the next one after my 0.21 was actually a 0.34. So it moved up pretty quick in a short time period, which is kind of what's weird about the way PSA can, one day it can be a little different than the next, especially in these small numbers. That seems like a large increase, but it could have gone back, which is why they wanted two results. That could have been a 0.34 and jump back to a 0.22 or 0.21, which is why Mayo was saying we can't even put you in the study unless you have two results. So I got the 0.34, I called it in. They said, okay, but you got to get another result. Go back. I can't remember how many weeks they said. Go back and get another one. And it also came in at around the same, 0.35 or something, really right there. So when I had the two results, I went up, did the PSMA scan, and they found the tumor. And they found the tumor. It was in the pelvic floor, but it was in the seminal vesicle bed, which sits right above where the prostate was. And it was just sitting there. And he said, your tumor is the size of my pinky fingernail. It's the smallest tumor that I'll be treating. And he was thrilled. And of course, I was thrilled that we had a test that found a tumor at its earliest stage, very small. I'm thinking this has got to be good. And they're never going to give you at Mayo Clinic or anywhere else any kind of hope that you're going to be cured of metastatic disease, because it's still considered incurable. But the hope is with this PSMA scanning, and they're having terrific results with the scanning, they're finding metastatic tumors much smaller and much more rapidly than they used to do. They used to wait till you were a 1.0 and do a PET scan that was reliable but not completely reliable, because some of these tumors, like a normal PET scan, sometimes wouldn't pick up a tumor that small. So they might have to do multiple PET scans before tumors would show up. But these tumors are showing up at very low PSA because of that radioactive material that sits on that membrane. It just gives these little lights on the scan. It shows you right where they are. So now we had a tumor that we could do some targeted radiation on to treat the tumor in addition to the ADT.
Okay, so if I'm hearing you correctly, Joe, not only are you an advocate for early detection so that it doesn't go metastatic, but if it goes metastatic, early detection for wherever those tumors are, because moving on it quickly, either prior to being metastatic or once it's metastatic, it still makes a huge difference if you can detect tumors, like meaning in both categories, early detection is going to be incredibly helpful.
Yeah, and I think people realize that in all cancers that's true, right? But in prostate cancer, now we have the technique to do it. And it's very new. And it's being used now much more universally. There's more of these scans available. They're out there. And the hospitals are now testing patients above a 0.25. So I'm not, it's probably a direct result of the Mayo Clinic clinical study, but they are moving off the 0.5 and getting people on that scan earlier. When you think about that, for men to get diagnosed with the tumor or tumors at a earlier, smaller stage, it must be so much better for the urologist to treat them now. Not all prostate cancer is the same, and that's something someday you can interview an expert in treatment of metastatic disease as to why all these tumors aren't the same. Some of the tumors don't even work they don't even accept the radioactive material on the membrane. So they are, I forget the word, but they're, let's just call it reluctant or whatever. They won't accept the PSMA material, so it doesn't work. It's a small percentage of patients. This is the most horrible diagnosis you can have with the ADT, is some cancer cells are what they call castration resistant. That means that they survive without testosterone. Those patients, unfortunately, are dealing with the most aggressive, most difficult cancer to treat. If you think about it, if the first line of attack is let's put the cancer cells to sleep and treat them either with chemo or radiation or whatever, or take out a tumor and treat the things around it, whatever their technique for treatment is on various types of prostate cancer that are in there. If you've got prostate cancer that's able to avoid everything, your first line of defense, it's more difficult that they're spreading those cancer cells seem to be spreading faster and being more aggressive and more difficult to treat. Not to say that they're not able to treat it, but if you look at prostate cancer research now, a large, huge portion of the dedication to prostate cancer research is how to treat castration-resistant prostate cancer cells. That is where they're directing a lot of their energy, because unfortunately that's the one where they're losing more patients. So they want to. The fight against that is a very vigilant, aggressive research, and all over the hospitals that are researching prostate cancer are looking into that and working on it.
Well, from what I understand, you were saying like the point of the ADT with the senescence is like it at least stops the growth. So it can now get attacked as it's not growing. But if it's resistant to that, it just means it's a different type of cancer, like you're saying, that will continue to grow
right
at some rapid rate. So trying to treat it with the chemo or the radiation, yeah, I'm sure.
And it's looking for its favorite place to form tumors, And so I think that prostate cancer treating doctors, these high-level urologists and oncologists who are treating it, will tell you when it gets into the bone, it's really bad. And so if you've got cells that won't slow down so you can treat them, or fall asleep so you can treat them, and they're just finding places to lodge and form tumors, and all of a sudden it's in the bone. Now you just constant. It kind of reminds me of these forest fires we're seeing in California, and all. They just keep popping up. You think you got the fire going out, and you just keep popping up. That's what I think they're dealing with. Is where are they going next? And all the organs in your body are susceptible to prostate cancer. Not all of them, but most of them. The liver, the kidneys, the lungs, and then the bones. Like I said, most of the time, because of the nearest to the pelvic floor would be the legs, but they're finding it in ribs, backbones, spine, shoulder bones. It likes bone. So one of the things they test you for is you do a bone scan to see if there's any evidence of cancer in your bones. That's an important test when you're being treated for metastatic disease.
So Joe, back to your story. Did you know that you were just about to embark on the hardest chapter in your journey? And did you know that the ADT would be so miserable?
I was so confident. Not only did I'm just going to call him the best doctor in the country and possibly the world, because he is. So that gave me a huge degree of confidence, and it still does today. I had no idea how bad the ADT was going to be. And it's necessary. But the sooner you can get off it, the better. I would hope the protocol that they can find that you can stay on it less time than they're doing now. It used to be 2 years that they'd put you on it for the treatment that I had with the radiation. But now they've reduced that to 18 months, which is far better. Having gone through what I went through, I wish it was only necessary for 6 months. I don't know what kind of research they're doing in that area, but if any doctors are listening, I wish you would dedicate time to this. You don't really know, because you haven't gone through ADT, how it was the most horrible part of my treatment. When I look back on it, surgery was nothing. I think I kind of look at the prostate cancer surgery, the way you talk, the prostatectomy itself, the way women talk about having a baby. They talk about labor and delivery, and then something that it just goes away. They're willing to have another baby within a year. Women are ready, to have another baby after all they went through to have a baby. I think that's what the prostate, there's something that just mentally blocks it out. It was just simple. There was nothing to it, really. There's hardly any pain post-operatively. Within a month, you're back to doing anything you want to do, play golf, lift weights, all that stuff. Your body's able to do whatever you want to do after a prostatectomy. So it's like a big nothing, really. So that people that are afraid to have a prostatectomy, okay, you're going to have a catheter after it for a week. You're going to be a little bit slow for a couple of weeks on your first week on your walking. It's a little bit, you've got stitches and things. So you got to be a little bit slow. You're still recovering mostly from the anesthesia rather than the surgery. There's hardly any pain. And it just becomes a big nothing. Then the radiation, the doctor who did my radiation at Mayo, who just I think turns out to be a great job, is the way everything's turned out, talked to me in great detail about all the side effects I was going to experience from radiation. He said, you're going to get weak, tired. A lot of men suffer nausea, diarrhea. He goes, you'll see me every week. You can report those things. We can treat some of those symptoms, but you're going to be really tired. Most men just want to sleep most of the day after radiation, all stuff. And I said to him, what can I do? Is there anything to prevent all that? And he said, well, a lot of men report that if they go on walks, it really helps. I'm thinking, okay, here I am in Rochester, Minnesota, February and March. There's mostly ice, and if it's not ice and snow, it's because it's too cold to snow. It can be so cold there. So I joined a gym, did 3 weightlifting classes a week when I was there. I brought my dog. I had this puppy who was at that time was 8 months old, and we were actively trying to train her. And one of the things she needed was a lot of walks. And I thought, well, walking's recommended. And my wife, of course, was like, you're bringing her regardless. She's your companion. And I thought, yeah, not only is she going to be my companion, which is really great, but she's going to force me to walk. So I walked her a couple times a day, and I'm going to weightlifting classes. I never had any side effects from the radiation. And I could either just be one of those people, or what I recommend to people, because of what I went through, is exercise as much as you can during radiation, because I think it fends off some of these side effects. But again, looking back, when I look back at the prostatectomy and the radiation, those were big nothings in the treatment. Radiation, of course, took 8 weeks. I lived in Rochester, Minnesota, except for the weekends. So yeah, it was a lifestyle change for 8 weeks. But looking back on those, side effects were really nothing. The side effects of ADT were horrible.
Now, this is an 18-month, originally a 2-year period is what you think it's going to be. Are the side effects compounding? Like, do you notice anything the first month of 0 testosterone? Like, when does it start getting to a point where you're like, this is like, where you feel like you're actually like suffering because of how bad it is?
Yeah, it's a very interesting question, because at the beginning, I was extremely optimistic because I had the shots, and your testosterone goes to 0 right away, and didn't feel any different. This was in 20. It seems like everything happened in October. This was in that October 21 time period when I had my first shot. Through the period of radiation, February, March, I have to have the ADT shot every 3 months to keep the testosterone at 0 every 3 months. So during February, March, I didn't feel any different. I didn't start to feel the side effects, except I started to experience a little more weight gain. One of the side effects of ADT is weight gain. I didn't think we talked about the side effects, but the side effects are muscle loss. There can be bone loss and even bone fractures, bone density loss and bone fractures. Those are pretty rare, but they can happen. It can lead to osteoporosis. That's why you don't want to be on it too long. But the ones like that you have are these hot flashes, like I said, muscle loss, weakness. You can have gynecomastia, which is the increase in your breast tissue. And then the big one is that I experienced, not everybody experiences as drastically as I felt that I did. Maybe they do, I don't know, but is this metabolic disorder and insulin resistance. And so what started happening in 2022 was I started noticing some weight gain, even while I was exercising and eating the same diet. Just that would be what I'd call unexplained weight gain, except I had an explanation. I was on ADT. If that happened at any other time, I'd be like, why all of a sudden did I gain 15 pounds? But it seemed to stick at like 15 pounds throughout 2022. I was slowly increasing 15 to 20 pounds in 2022. But in 2023, which is now, I started in October 2021, late 22, early 23, I clearly went into metabolic disorder. And the reason I know that is I'm a type 1 diabetic, and I've been type 1 diabetic since age 35, and I inject insulin myself. Type 1 diabetes is the diabetes where the pancreas does not produce insulin, so you have to self-inject. You become a pancreas. You have to inject your own insulin, or you get a pump that does it for you. So I also have a continuous glucose monitor that tells me my blood sugar. So I'm taking my sort of normal doses of insulin, and my blood sugars are just going out of control. They're staying high, very high. So I would take more insulin just to get it down to normal. I got to the period in late 2022 all the way through 2023 of taking at least 5 times the dosage of insulin. Any endocrinologist listening right now is horrified to think, oh my God, that's just going to cause weight loss like crazy, weight gain like crazy. I wish it was weight loss, weight gain like crazy, because you just get into this vicious cycle where your body is insulin resistant, which causes weight gain. You have zero testosterone, which causes weight gain, because at the same time with the zero testosterone, you're losing muscle mass. And one thing that fights weight gain is muscles. Muscles will absorb calories and help you to metabolize faster, and metabolism is going down because you're losing muscle. And then the vicious cycle of gaining weight. In 2023, that 15 to 20 pound weight gain crept up faster and faster to the point it got to 50 pounds. And got a little bit above 50 pounds once, but it was mostly right at about 50 pounds for a long time. I was 50 pounds overweight and lost a lot of muscle. And that was a horrible thing. And in addition, having hot flashes every day. So,
I mean, I'm sure they can prepare you for it, but it's different when all of a sudden you're experiencing, you said, minimum 5 hot flashes a day?
yeah.
And instantly, you'll just be out and about with people and you have to explain why all of a sudden you're sweating uncontrollably.
Yeah, I had very interesting experiences with that. So the hot flashes are caused by the hormone imbalance. Women go through menopause, their estrogen levels reduce tremendously, so they go into a full hormone imbalance and have hot flashes. So every woman listening to this will say, good, finally a man is talking about hot flashes. I love to hear this. But I understand everything they go through. All the women listening, we're a team now. This is a horrible thing. It's horrible. It's miserable. I would get 5 a day would be a good day. As many as 12 to 15 happened, but 5 to 10 a day was standard. Most of mine, fortunately for the rest of the general public and my family, most of them happened while I was in bed at night. But a lot of them happened during the day. And, and at this time, now we're in 2023, 2022, 2023. So we're back to going out together in public. So you'll be out to dinner with people, and all of a sudden it just starts sweating profusely. Of course, everybody thinks it's the guy having a heart attack. Some of them don't even know what I'm going through at all. They don't know I don't sit there and talk to everybody about my ADT, but sometimes it starts the conversation. Like, what's wrong with you? Oh, it's a hot flash. Like, that's really funny, Joe. What's really going on? Are you having a heart attack? No, it's a hot flash, and then you have to explain why you're having a hot flash. But the ADT causes your testosterone to go down to 0. So you have a complete hormonal imbalance. Just like a woman's estrogen goes down, your testosterone's going down. We have testosterone, estrogen. Women have estrogen, testosterone. But for us, testosterone, we have more testosterone. They have more estrogen. But you need the balance of testosterone and estrogen. And when one of them gets out of whack, and going to 0 is out of whack, that's imbalanced. It causes a vasomotor response because the hormones play a role in temperature control through the hypothalamus. And all of a sudden, it's like the system for temperature control has gone haywire. And it tells you the vaso is the vascular part and the motor is the neurological part. So it tells you the message is sent, body needs to get warmer. For no reason. It could say that on a 80-degree day. Body needs to get warmer. Why? Who knows? It's just out of control. It's just like a machine that's lights are blinking, everything's going screwy. And so you get a hot flash. And then the immediate response to the hot flash is vasomotor response is, okay, now let's start perspiring to cool this body down. And so now you just have full-on flood of perspiration to cool your body down. And you go through this for about 5 minutes or so. And I explained it on a video I did in the talk that I gave, and I explained it to people, is I've spent enough time around hot water heaters to see if they're working when you have to relight the pilot light or whatever, and then you see it, you hear it go on, and then you feel it, and you feel the water heating up. That's what a body feels like. It feels like somebody just lit a pilot light, and for no reason, you just start heating up. For me, it went from the top up and my shoulder level up into my head every time. Sometimes it went down to my legs when I was sleeping and my whole full body. But when I was standing up, it would just kind of be up. But you just go into a full sweat. And at night, it would be full on sweat to the point where the pillow was soaked. Be exaggeration to say you could wring it out, but it's not too far off. I mean, soaked. And then you get, whether you got air conditioning on or whether it's winter, whatever it is, then all of a sudden you fully perspire. Now you went from hot to cold. And this is happening a couple times during the night, or at least once every night, sometimes a couple times. The lack of sleep starts to get draining on you. So the hot flashes are horrible. And men, I'm empathetic, very empathetic to the women that go through this. But if you never have to go through what I just went through, be empathetic to your menopausal spouse because it's horrible.
It just sounds like this came out of, I don't want to say nowhere, but it's like, here you are and you're getting treatment so that you can keep this disease contained, stop it from growing. It's all positive news. You're excited. You know, this is a really great oncologist. Like everything's going great. And yet you're probably not expecting, you've always identified as just a very healthy, active individual. And for the first time in your life, you're actually overweight. And now you're experiencing this metabolic disorder. You're experiencing hot flashes. And it's, man, like I'm just trying to treat my cancer. And all of a sudden, like my whole body's changing. You probably, like, tell me about that. Because it seems like you probably weren't expecting the severe weight gain.
No, I wasn't. I was told I was going to get fat. They said you're going to get belly fat. And you're just going to be a fat, lazy man. That's what you got to expect. Because you're going to lose your energy and you're going to get fat. That's what happened. Men just, on ADT, just sit on the couch and have hot flashes and watch TV. I thought, well, that sounds great. So, I'm going to keep working out, which I did. I never stopped working out through this whole process. And,
but that didn't stop the weight gain.
No. And prior to prostate cancer, I had always, I think my whole life, I've been 10 pounds over the weight I wanted to be. Sometimes I'd get 20 or more pounds, and then I'd go on a diet, and I'd get back to that 5 to 10 pounds overweight, always trying to lose the 5 to 10 pounds. I can tell you right now, if I can get down to 10 pounds, I'll never complain about being 10 pounds overweight again, because being 50 pounds overweight is horrible. And emotionally, especially having been someone who kept my body in good shape through diet and exercise, was always in good shape, because remember, I got diagnosed with diabetes at age 35. So I stayed on when you get diabetes, they tell you could die from diabetes. So, I mean, being physically healthy was very important to me from age 35 on. I was really working at it. So, like I said, I was always fighting 10 pounds, but 50 pounds, it was, I wouldn't say, I hate to use the word depressing because now we're getting into a medical term, but it was let's call it emotionally distressing, especially when I'm at the gym looking in the mirror. They give you, gyms are filled with mirrors when you're doing weightlifting so you can do the proper technique. And for some guys, because they want to look at their body, but I didn't want to look at my body. In fact, sometimes I would do the weightlifting not looking at the mirror because I'd look, what has happened? My muscles got smaller. I just am so fat. And I didn't want to be seen in public, really. I was like, people are going to think, what? This guy's just lost it. He used to be all into physical fitness. Now look at him. Of course, that happens to guys like him who just are lazy and eat and drink too much, whatever they're thinking, not knowing what you're going through. It's just a horrible feeling of all of a sudden you feel like for the first time, no, I don't want to go be at a big party tonight. I don't want to go see people. I don't have clothes that fit. Let's just put it that way. What am I going to wear? I don't have anything that fits for a party. That's how bad it gets when you gain 50 pounds. You start to changing your wardrobe. So everybody's saying, well, this guy's whining about his weight gain, but it's hard when you put it on, despite doing everything right, you're putting it on. You just feel like you're pushing a boulder up a hill. That's how it felt.
Yeah, like you're out of control.
Like my body's out of control. A guy who kept his body in control, kept my blood sugar in control, never having an A1C over 7 because I keep my, as a type 1 diabetic, you see the ads on TV. My A1C is under 7. Well, mine was always under 7. I have tight control on blood sugar. and to have my blood sugars out of whack, to have my weight out of whack, to have my muscles depleting despite lifting weights. I was in this downward spiral, and it was tough.
So you were probably waiting for when this ADT was over, and I'm guessing what your testosterone immediately responded and went back to normal.
That's what I was hoping. I could not wait to end the ADT. I actually wanted to end it sooner, and my doctor said, no, stick with the program. You're going 18 months. That's the protocol. I said, but why? I still ask why. And again, I'll ask the researchers, please find out why it can't be 12 months or 6 months. But at 18 months, I had my final shot in February of 2023. The shot lasts 90 days. So in May of 2023, that shot would wear off. And in my hopefully half glass full optimism, thought, okay, when I do my June test, I'm going to have testosterone back. No, it did come back. It was a 10. And then I said to my doctor,
just give a scale of reference for that.
The reference is low T. You are diagnosed as a man as having low T, something that might need to be treated by testosterone replacement therapy, even is 300 and below is low T. That's very concerning for a man to be below 300. A woman, testosterone level, normal level for a woman is 30 to 90. Some might have a little more than 90, but it's 30 to 90. I was at 10. And I said to my primary care doctor, could this be right? He goes, you know what? Let's just check it again, just double check it. Now, testosterone test isn't like a PSA test. It's not result next day, unfortunately. It's more expensive, but we did it, and it came back at 0. So he said, let's wait. Now we're going to just wait until the end of July. We're going to do it again.
Now, waiting, are you trying to do anything to supplement? Do they have medication to try to stimulate testosterone?
One thing they would not do, there are some doctors that talk about that maybe we can do this, but with prostate cancer, since it feeds on testosterone, the last thing that a urologist or a prostate cancer treating doctor is going to do is to give you anything to enhance your testosterone.
So you have to wait for it
They
to
would like it to
naturally
come back naturally, but quite frankly, I think they would like it to never come back, so they don't have to. So they don't have to see this thing metastasize again. But not really. They want it to come back. They want you to get back to normal. But I waited till the end of July, and the next testosterone reading was 8. So you can imagine how frustrating that's getting. So, and I'm still now.
You're still having hot flashes?
Still having hot flashes. I still can't lose weight. I'm still losing muscle.
So you're not going through ADT, but you're still experiencing the side effects of ADT.
I'm still, the side effects of ADT are the side effects of 0 or low testosterone. So yes, I still have 0 testosterone or 8. What 8 is?
It's 0.
0.
It's not anything on the Richter scale.
Like I've said to my friends and stuff, I'm not even a woman yet. I want to get to a woman level, but I was at 8. So then the next test we were going to do is October, 3 months later. So I did it end of October and my 2023 now, and it was 377. So at 377, that's a little above low T, but it's way above 0 and 8. So I was thrilled that it had come back.
Now, did you know that because some of the symptoms had disappeared?
Not yet. No, the symptoms hadn't disappeared yet. I was hoping.
You're still having hot flashes.
Yeah,
380.
Well, I was hoping that was the first time it came to that. So before that, it was 8. So during those 3 months, I didn't really feel any change yet. And remember, don't forget, below 300 is low T. So
okay.
377 is just above low T. So even during that 3-month period before that blood test, I'm still at low T. So with low T, you can have some of these same experiences. But so my doctor, my primary care doctor, who's like I say, he's a great doctor, and become a good friend and a good confidant. He's just like, Joe, one day your pituitary gland is just going to turn back on. Don't worry. It's going to happen. He's like, but when? He goes, don't worry. One day it's just like flipping the switch. It's going to go back on. And so the switch was flipped. Testosterone came back at 377. And then the next test after that, I was 760s. Or not the next test. Then it came back in the 400s. So I kind of climbed up to the 400s. And then the next test after that, I got to 767. The most recent test I just had in May was 572. Now, testosterone can have these swings, but having a 767 and a 572, if I can stay anywhere near 600, which is very good for a 64-year-old man, I'm just really happy with that. And that has changed. Things have started to change now. Oh, the hot flashes have been gone since I was in the 400s. Gone. Just the switch came on for testosterone. The switch went off for hot flashes. The weight gain's been a slower story. Weight gain that I had, the losing it's been a slower story.
Did you celebrate when all of a sudden finally you were a man with normal testosterone? Was there something where it's like, because this was the darkest part of your story, was the metabolic, so the metabolic disorder, also with the insulin, everything started regulating?
The metabolic disorder has taken a long time, but I'll tell you a little story about how that has changed and is better now. Today, as we're sitting here today, it's gone. But that was an interesting and very tough battle. But did I celebrate when my testosterone came back? It was one of the happiest days of my life when I opened the envelope. I opened on my phone the result, you look on your app. When I still call it open the envelope. When I opened the envelope and saw the 377, I wanted to scream out to the world, it's finally back. It was such a good feeling. I was so happy to be at 377.
Was this kind of the end of your journey as far as, like, is there then just like ongoing now maintenance to make sure that your PSA levels?
Now there's a new scary journey, because remember what we talked about. Prostate cancer cells feed on testosterone. And as far as I know, prostate cancer cells could still just be sleeping from the ADT. So when do they wake up? What's going to wake them up? The doctors will tell you what's going to wake them up is testosterone. I'll be like, oh, the food's back. I'm oversimplifying this, but so when the testosterone rises, the fear is then the PSA is going to rise. Now, when you're on ADT, you want your PSA should be non-detectable because you have zero testosterone. The men that have detectable PSA when there is ADT, when they're on the hormone therapy, they're the ones that have the castration-resistant recurrent prostate cancer, which is that horrible aggressive cancer I talked about earlier. So mine was zero the whole time I was on ADT, which is good because the ADT is doing what it's supposed to do to put these cells asleep and slow them down. So then the fear is, okay, now I've got testosterone. I have to do a PSA test every 3 months. And the thought is, when I do that, is the PSA now going to start being detectable again? I mean, if I get a score of 0.05, that means it's back. 0.0 anything above 0.02 as it's back. Otherwise, it's considered non-detectable. So every time, again, I open that envelope, because I'm old-fashioned, but open the app and look at my score, immediately the next morning after PSA test and see it's non-detectable, that's a really happy moment, because I have rising testosterone and non-detectable PSA, and that's what's been going on since October of 2023. We're in August of 20, or as we sit here today, August of 2025. So I still have non-detectable PSA, which is in the face of rising testosterone, which I think is a real good sign. Of course, my doctor thinks it's a good sign, but of course he tells me you're not out of the woods yet. It could come back at any time.
But still, every year that you have good levels of testosterone and non-detectable PSA is a year, I don't know, closer toward just maybe more peace of mind.
Yeah, and like I said, metastatic disease is, to this day, is considered incurable. No doctor will say it can be cured. They'll say it can be cured by removal of the prostate and no metastasis, getting it out, contained. And the localized prostate cancer can be cured. And that's my message here, is get it out while it's localized and neatly, tightly wrapped in a package. You can pull it out of your body and live without a prostate, instead of living with metastatic disease the rest of your life and knowing you have an incurable disease that can be affected by something as simple as testosterone. I don't want to ever have to go through ADT again. I think the worst part about it coming back is if they tell me you got to start ADT again. I would hope there's some other treatment by then. I think the longer I go with non-detectable PSA, meaning hopefully meaning there's no cancer. I'll tell you about that in a minute. Then these doctors that are these brilliant doctors, they're everywhere. They're at Northwestern, Johns Hopkins, Mayo, MD Anderson, USC. You think of all these great hospitals where all these doctors are just focused on prostate cancer research. They come up with all these new treatments. PSMA was one of the great ones. They've come up with the chemo treatments are better now. This fight against these castration-resistant prostate cancer cells is getting better. That they would love to find the way to really beat these cells before they can get tumors and all throughout fulminant cancer through multiple organs. But they're working on it every day, and I think every day that I have non-detectable PSA, there's brilliant doctors get up every morning and go to work thinking about how are we going to stop this disease and how are we going to cure it. They're not there yet, but they're trying every day. So every day I get a break while they're working on it, the better the chances if and when it comes back, there's going to be even a more advanced treatment. That's the hope. That's the hope for all of us. The longer you don't have it, the better those doctors are going to get at treating it. The next step for me is in November, I'm going to do a PET scan. Now, I don't know which one he's going to do. I got to talk to my doctor. I don't know if we're going to do a PSMA again or he might do this choline PET scan, but I'm going to do a full body PET scan. And of course, I asked my doctor, I said, I have a 0 PSA. In the face of rising testosterone, why are we doing this scan? He said, because unfortunately, 12% of the metastatic prostate cancer population have tumors that are growing that are not throwing off PSA, not even throwing off PSA. There's so many. That's why I say this is not as simple as maybe I'm making it sound sometimes, but there's so many different prostate cancer cells out there that are doing different things. And he said, we need to look. We just need to make sure there's nothing out there brewing that isn't showing up in your blood testing. So
I think it must even just be weird psychologically to know that the better you feel because of a pro-testosterone environment is also the same environment that could lead to a recurrence or I don't know what the medical term is.
Recurrence, yeah.
Recurrence.
That it comes back.
So it's got to be this weird oh man, I love feeling great as a man with testosterone. I feel healthy. I feel great. And yet that could contribute to a recurrence, which would be worst case scenario.
And the opposite is another sort of crazy thing about medicine is the thing that they use to treat it, this ADT, used long term can be very harmful to the body. Okay, think of all the money and energy that goes into all the ads you see on TV, epidemic of people that have type 2 diabetes, which is insulin resistance. That's what type 2 diabetes is. It's metabolic syndrome with insulin resistance, right? They're spending a lot of research, a lot of time to try to reduce the diagnosis and of type 2 diabetes. Stop having people come up with type 2 diabetes, which is generally caused by obesity. I became obese. On top of my type 1 diabetes, I got type 2 diabetes. I was fighting both diseases, right? It's so bad for you to have obesity and type 2 diabetes being insulin resistance. It's bad for your heart. It's your cardiovascular system is destroyed by it. It gets over time. Your nervous system, you can have nerve deficits from type 2 diabetes. They want to stop type 2 diabetes. And in the prostate cancer arena, they're giving you a drug that can lead to insulin resistance to fight the cancer.
It's almost like there's two competing diseases that you actually have right now.
So they're like, well, we need to fight the cancer, and a little insulin resistance is far less risky and hopefully only temporary. Well, mine is temporary, luckily. I would not want to be on, like I said, the ADT ever again or any longer. I don't want that to come back because it's a horrible battle. But
That's just such a weird dynamic that you're
Yeah.
saying. So the ADT is great for a anti-metastatic prostate cancer environment,
yeah.
but it's very bad for type 1 and type 2 diabetes. And yet,
Well, no, it's bad for anybody.
okay.
It's bad because the side effect, I mean, you could be somebody like, I'm assuming you don't have type 1 or type 2 diabetes, but someone like you, and then all of a sudden you're fighting the same thing a type 2 diabetic fights because of
I see.
ADT. All of a sudden you're thrown into it. Now, they'll say, well, that's only going to be temporary. Okay. Yeah, but patients that are at very high risk for problems from ADT is somebody who already has pre-existing cardiovascular disease, maybe clogged arteries, or they have other types of heart conditions. If they take this drug that can affect the heart, they're at high risk of dying from heart attack or stroke because of ADT. So the doctors who are prescribing ADT, obviously there's a complete medical history and an exam, everything from EKG, everything to make sure that their patient's healthy enough to even do ADT. I mean, if there's risk to that treatment, and believe me, the doctors are on it. They know the risk, so they're careful in their use of it. But they have to. The goal is to get the prostate cancer under control. In most cases, you're going to see treatment with ADT, and most patients at the early treatments.
So Joe, tell me, in the men that are coming and talking to you, what do you feel like are some of the common misconceptions that you noticed that they have as they're kind of trying to, talk to you about their experience?
I think you mean their experience before or with?
I guess I'm guessing most of them are talking to you as they're having prostate cancer.
No, most of the men are talking to me because they all of a sudden know that I have it, and they heard of somebody else who got it, and they were interested in what it is and how do you get diagnosed for it.
Okay.
And they learning about PSA. I also do talk to men who have been diagnosed with it and now want to know what are the next steps. So I do have both, but I would say most of the men I talk to are now curious because they didn't know. They're like, you're my age and you got prostate cancer. I thought it was for old men. That's a common misconception. Like I said, the average age is 68. Well, to get to an average age of 68, guys in their 50s are getting it and guys in their 80s are getting it. I mean, we all can do math. So, yeah, you think it's for the older people because that's all you ever hear about is this is a disease you live with and you don't die from. So there's this whole energy out there in the medical community to spread the word that this is nothing to worry about. And so men don't want to ever worry about getting sick because we don't get sick. We're men, So they realize, oh, somebody can get sick and you can actually die from this. I heard you can die from it. So now I want to know how you get diagnosed with it. How do you treat it? So, yeah, I get a lot of those from people who don't even have it. Just curious. I thought it was nothing. Well, how did you get it at a young age? How come people die from it? I heard people are dying from this now. So, yeah, I get those conversations because I think there's been this misconception. Just don't even worry about it. Just don't. If you get it, we aren't going to worry about it.
And this is something that it is significantly more probable if it's already in your family line. So if you're a man right now, it'd be a good idea if you're a man. If you're a man,
well, there are women listening, so they don't have to worry about it. But they have to worry about it for their men. Believe me.
Post 40, if you're a man, it'd be good to have that conversation if you haven't already with your father, just to find out, or your mother, I guess, what's in the family line.
This is a very important point. You must find out what your family history is, specifically for prostate cancer, for sure. Because if it's in your paternal bloodline, your father, your uncle on your father's side, or your grandfather, and then or your brother have prostate cancer, you're at a 2.5 times more likely to have prostate cancer between the ages of 40 and 45, which is that aggressive prostate cancer. And that's certainly something you need to report to your primary care physician when they say, what's your cancer history? And you maybe don't know it. You're looking at it going, I don't know if we have breast cancer, prostate cancer, pancreatic cancer. There's this list of check boxes. You better know if you have that prostate cancer on there. So then your doctor will say, oh, who had prostate cancer? If they don't ask the question on the questionnaire, who had prostate cancer in your family? They say, well, my dad had prostate cancer and his dad had prostate cancer. They're going to say, we're going to do a PSA test today. They're certainly going to do a PSA test when you're 40. And quite frankly, the new, I think, protocol is going to be, it's coming. It's coming. If it's not there, a lot of doctors are starting to do PSAs at 40 to get a baseline. But if you have it in the paternal line, they better be doing it at 40 because it's scary. You have a high chance of getting it. If you're a black man, which is the most complicated of all men, or is our black population, their prostate cancer is harder to detect because they can have it at lower PSA. They have different types of cancer cells that are more aggressive, more likely to. 1 in 4 black men will get prostate cancer, and a higher percentage of black men will die from prostate cancer than white males. So you, as a black man, want to get diagnosed as early as possible and treated. And you're not, just like all of us, you're not going to feel anything when it's inside the prostate. You might be told that it's normal. If there's any group that needs to be the most vigilant, you got to put those two groups: the men who have it in their paternal history or the men who are black. You should be the most vigilant on getting PSA test early and knowing your PSA level, watching for any changes, talking to your doctor constantly about it to make sure that you're on top of it to get it while it's localized and can be cured, because metastatic disease in either of those populations is the worst prostate cancer that these doctors all over the country are treating.
So in my research, I think one of the things that was fascinating, Joe, is that because of the weird nature of men not wanting to talk about it, if you combine that with the older generation, so anyone in your age range, there's a chance that if their father or his father had it, if they got diagnosed with it later in life, there's a chance, because of the nature of them not wanting to talk about it, that they may brush it off and be like, oh, it really wasn't a big deal. So I guess the whole point there is, like, you could be a 60-year-old man right now and be like, oh, well, my dad never told me he had it, so chances are he doesn't have it.
Right.
And that, just by the nature of we don't talk about it because it's kind of a weird thing to talk about, it doesn't mean it's not in your family line.
Exactly. So before you go to your doctor tomorrow, hopefully everybody's going to watch this and go look up their PSA or make an appointment to do your annual physical. Learn your family history. If your dad's still alive, talk to him. Did any of your brothers have prostate cancer? Did your dad? Like you said, men don't talk about it. And your dad's not going to talk about his dad's prostate cancer because he probably didn't even know. Back then, they weren't even diagnosing prostate cancer. We might not know, but your dad in his 80s or early 90s right now would know if he has prostate cancer. So you need to know. He might not tell you. In fact, mine didn't tell me. And I knew my uncle, his brother had it, so I had reported that to my doctor, so they knew I had it in the paternal line, so that concerned them. But I think he got diagnosed around the same time I did, which I was 58. I think he was 88 or so. I learned later when he got diagnosed, but just thought, this is nothing that I even treated. I'm not going to worry about it. So that would have been nice to know. But I think a lot of men won't know unless they ask. Also, find out the history of all cancers. All cancers need to be reported to your doctor. Women who, in your family, who've had cancer before the age of 60, your mother or your sister, puts you at higher risk for prostate cancer. You'll hear a lot now, and I don't know enough about it except to know this. There's this BRCA1 and BRCA2 gene, which they're starting to see as a gene that's responsible for breast cancer and ovarian cancer, now pancreatic cancer, and most recently, prostate cancer. So if all of a sudden you're hearing everybody's talking about, you hear it, you know why you hear it? Because women talk about it. Just like I said, they're a dynamic force. They know everything about breast cancer, even if they don't have it, because they talk, they communicate. And you'll hear women talk about, oh, so-and-so's got the BRCA gene. I got a test for the BRCA gene. What's the BRCA gene? Well, thank God they're on it, because I just talked to a woman the other day. She goes, I found out my son has the BRCA gene. Like, she goes, so now he has to be tested early for, I go, yeah, he needs to be tested early for prostate cancer. I'm glad that you found that out. I'm glad you know it. I'm glad you know that means he's, got a risk of prostate cancer, because nobody knows. This is something that hardly anybody knows yet. So if you hear you've got a BRCA gene somewhere in your family, your mother's line, or now your father's line, if somebody's reported it, that's got to be reported to your doctor. That's going to be, these are like flashing warning lights for your primary care physician that we need to be very vigilant about your prostate cancer. So know your prostate cancer history in your family. Talk to everybody. Your sister might know more about it than you do. So talk to your sister, whatever. Find out who knows our prostate cancer history, write it down and turn it in to your doctor. Let them know.
So Joe, one thing that strikes me is that here you are as a 35-year-old, you got diagnosed with type 1 diabetes. So you've been getting regular blood work.
Mm-hmm.
You're an attorney that has no issue researching different medical treatments or medical issues. You have access to great care. Here you are, you get prostate cancer. And even given all the, you being on top of it, you being very educated, you having access, it still becomes metastatic. What would you have done different, or what advice would you give so that someone can detect it early and not have to face the metastatic disease?
I think a couple of things I've already said. Know your cancer history in your family. Really important, because if it's in the paternal line, you're high likelihood of getting prostate cancer. If you're Black, you have a high likelihood. So you've got to be on it early. But I think looking back at it, and what I hope changes, is I hope everybody gets a PSA at 40. I hope everybody knows their PSA level. And looking back on it now, I know that a 2.5 is concerning, and you should be on it with your doctor from that point forward. Probably not a PSA test every year. Maybe they'll do one in 6 months just to check. And if it's still, let's say you're at 2.5, you do it in 6 months, it's still at 2.5. They might say, okay, now we'll do it in a year. And that's probably okay. But let's say they do it in 6 months just because they're concerned at 2.5 and it's a 3. Now I think they're going to get you to a urologist because there's something growing. But I think they're going to be more vigilant on top of it. And you have to be on top of it too. So know your PSA level, get it early. Even if your doctor says, oh no, we don't do PSA to 55. You say, I want to do it. My insurance should pay for it. If they won't, I'll pay for it out of pocket. I want to know what it is. And when I say I say that like nonchalant, easy to pay for it. It's going to be a little over $200 to get that test. Not everybody can just pay that. But if you can, do it. But if you can't, get your doctor to go to bat for you and get it covered by insurance, especially if there won't be a problem if you have it in your paternal bloodline or your Black man. Insurance should cover it, because if they don't, that should be appealed. I mean, you're at high risk. Everywhere, every doctor recommends that those two groups get it at 40. So if your insurance company won't pay, then you fight them, because you got to take them to the mat. You got to fight them and get your PSA test. So the other thing I think you just have to do is make sure that you understand that it's asymptomatic. I think that what I hear so much, and when I even talk to people, it's, I'm healthy. And they'll tell you all the things they do, and it's great. You look at them and go, yeah, I can't ride 30 miles a day on a bike. No, I don't go to the gym 5 days a week. No, I'm not 6 foot, 180 pounds like you are. I mean, yeah, you look healthy. I can almost understand why you don't go to the doctor. But if you're a otherwise healthy man, get it out of your egocentric, persona that you're so healthy you don't need a PSA test, because you do. Get it, because you're going to feel a thing. If you're healthy and you're riding a bike and you have a strain in your hamstring, you hurt your hamstring. Nothing's going to hurt when you have prostate cancer, okay? Nothing's going to tell you. Your athletic pain that tells you what you got is different than prostate cancer. There is no pain. There's nothing. Asymptomatic inside the prostate. If it is symptomatic, that means it's outside the prostate, and that means you're in trouble. If you come in with all of a sudden a fractured bone that is unexplainable, or I can't breathe, or you bloody stools, well, all of a sudden that's probably because cancer has invaded some organ or your bone. You didn't even know you had it. It's metastasized. Now you're really in trouble. So better to catch it while it's inside that prostate.
So Joe, in terms of what you would have done differently, I know you just kind of mentioned a whole list of things. But I didn't hear something specific about active surveillance. Is that something that you might have done something different with?
Absolutely. For me, in hindsight, I would not have done active surveillance. In fact, I've encouraged others to not do it. And I can tell you one story about a guy whose life I saved for metastatic disease because of that. It is for some people. I mean, again, it's up to the doctor. It depends on your age. It depends on a lot of factors. Different blood tests the doctors will do. But in my case, my cancer was more aggressive than originally thought. And that's why I ended up with a Gleason 7 score on my follow-up biopsy. I don't know when the wall of the prostate broke, but obviously I had a better chance of getting it out before metastasis sooner rather than later. The mistake I made was even when he told me we'll do active surveillance, in my mind, I knew I was going to take the prostate out. In my mind, for sure, it was going to come out at some point. I was just putting it off. It's like procrastination. I just put it off. That was the mistake I made. I should have just taken it out when I knew it was going to come out in my lifetime, in the next year, next 2 years. If he said possibly 5 years, but in the next year or two, I was going to take it out. I wish I had taken it out the day he gave me that option, said, no, I don't want to do that. I would rather get it out now. I know I'm going to take it out maybe a year or two from now. I'd rather get it out now. Had I done that, I think I could have avoided metastatic disease. We wouldn't have known because we just don't know. We can't look back and know that, but I think there's high likelihood I would have. I had a friend who, at a dinner conversation, asked that question about how do you get diagnosed with prostate cancer? I gave the whole scenario about the PSA testing. I gave him the scenario. I said, I talk to a lot of men who have never even had a physical. They think they're healthy because they don't get sick. They every once in a while get a cold, but they walk, they hike, they ride bikes 30 miles. They're the most perfect male specimen, but they don't get a PSA test. And so I said, why? You got to get the PSA test. It's a simple blood draw. It'll take less than 2 minutes to do this. He looked at me and he goes, you know what? I'm one of those guys. He's my age. At the time we were talking, he was 62 years old. He's my age. He said, I've never had a PSA test. In fact, I haven't had a physical for about 10 years. And he goes, and something else? You talked about the bloodline thing. My father died from prostate cancer. I literally jumped out of my chair. This is a friend of mine, so I could do this. I said, I thought you were smart. You might be the dumbest man I've ever met. I mean, this was one of my good friends. I yelled at him. I said, you have prostate cancer. I'm just going to diagnose you right now. You get your PSA done tomorrow. He did. He went in the next day. His PSA was a 5.6. They did the biopsy. He had Gleason 6 prostate cancer. I said, now they're going to tell you can do active surveillance. And you tell them you're not going to do active surveillance. At the time I was having this conversation, I was driving to Mayo Clinic. I said, because I'm driving to Mayo Clinic right now for one of my follow-up scans. And I said, and I don't want you in the car when I drive up here the next time, because we're not driving up here together. I don't want you to have metastatic disease. So you just tell the doctor you're taking it out. And so he did. And he took it out. And he said he has one of the best doctors in the country who wrote this book I'm going to tell you about in a minute, with a doctor that I think people should read. He was very optimistic about his treatment and everything, and glad he was taking it out, did the surgery. And my friend said, for the first time, I was concerned because he said, when I asked him how to go, he said, we're waiting on the pathology. He said, I immediately knew in my gut something might be wrong. But they came back, and he called me. The pathology came back, and he said, I think you're the luckiest, just about the luckiest man alive. He goes, you had a tumor pushing on that wall. And I can't tell you it would have broke in a week or in a day or in the next couple hours. That thing was on the verge of busting through. And he goes, you got it out just in the nick of time. So, yes, it's very important. And some cases, active surveillance is wrong. I think you just have to know if it's in your mindset that you want the prostate out and you're just putting it off like I was, don't do it. If your doctor strongly recommends that you don't need to take it out, maybe never, and they have reasons for it, really question why. I could see that conversation being absolutely true for somebody over 75, slower growing cancer. But I say if you're in your 50s and your 40s for sure, if they're talking to you about active surveillance in your 40s, no. The answer is no. I don't even think they will. There might be a doctor that would. I don't think they will. But in your 50s, as you're getting in your early 60s, they might start talking to you about it. I would be asking a lot of questions and be very careful on it so you don't end up like me.
So, Joe, you've done a ton of research and you've checked out all these different resources. Are there any that you would recommend almost as a next step follow-up? Someone's watched this video, they've watched this podcast. What would be a good next step for them to check out if they want to learn more?
I just almost mentioned a book a minute ago that I want to tell people about. There's a book called Patrick Walsh's. He's a doctor at Johns Hopkins University, Dr. Patrick Walsh, Surviving Prostate Cancer. It's out now in the 4th edition. When I got diagnosed, I bought, I don't remember if it was the 2nd or 3rd edition, one of the earlier editions, read it from cover to cover. It's a very good book to learn everything you need to know about prostate cancer. It'll answer every question. But one thing I learned when looking into this 4th edition recently that I didn't know is it came up when I was researching something on a podcast. I go, oh, here's his book. There's an audio book. You can just get on the podcast, look up this book, and there's somebody who will read it to you, the whole book, chapter by chapter. You can just sit there and listen to it in your car. You can listen to it wherever. And it's great. It's very informative. My doctor, Dr. Eugene Kwan, is something I highly recommend getting on Google or whatever to find his lectures. Once a year, he does a lecture to patients on advanced stage prostate cancer, and he calls his series the Combat Manual for patients on everything that's going on in prostate cancer, everything they're doing to research, new treatments, up to the date, once a year, update on what is going on in the prostate cancer treatment world of first diagnosis, but also mainly metastatic disease. And his lectures are geared toward patients. Some of them are an hour long. Some of them are 2 hours and 45 minutes long. But whatever they are, they're worth every minute. His lectures are fantastic and directed to patients. It's Eugene Kwan, is Kwon, MD. He's at Mayo Clinic. And like I said, if you put all that on a Google search, his videos will pop up, and they're an annual talk.
Well, just to let the listeners know, we'll include the links to everything that Joe was just talking about in the YouTube description or the show notes of this podcast, so you can just check it all out there.
Great. Thank you very much.
From everything I know about you now and even hearing your story, it's like when you had prostate cancer, you weren't someone that was just trying to tell everyone. You weren't being super vocal about it. You maintained your privacy. And then it got to a point where it's like afterwards, you realize through these conversations with men that are curious about it and men that have it, that wait a second, the education I'm providing can save lives and has saved lives.
Mm-hmm.
And that's why I just think it's so important that you have this platform, because your decision to say, you know what, like these might be some awkward conversations. This might be some topics, we're talking about penile health. But it's so important for people to know this so that they can, again, seek early detection and, again, have a metastatic-free life. I absolutely love what you're doing. Right now, if there's a man out there or if there's even someone that's part of a Prostate Cancer Awareness Foundation and they want to get in touch with you, either just personally to reach out or to hire you to speak, how would you like them to contact you?
I'm in this process of my public awareness campaign. I'm going to have a website where I can be located. I'm on YouTube right now. Wish I could remember I think it's at josephdooley.com, but I need to, it's so new I need to look it up.
I can put it in the show notes.
Why don't you put it in the show notes? But you could contact me directly if somebody's interested in having me talk to a group, or somebody needs to talk because they just got diagnosed, let me know. But I'll probably send you to my video first, or this podcast, because a lot of the things I would say to you over the phone, I've already said here.
Joe, thank you so much just for being unselfish, for just having the courage to say, you know what, my voice matters in this. And I think you're so uniquely positioned, Joe, because of that 35 years of you taking complex, medical terminology and understanding and finding a way to be able to communicate it in a way that just lay people could understand. And I think oftentimes the tragedy is a lot of patients just take verbatim what it is that the doctor says, and or maybe they don't know where to give pushback, or maybe they don't actually know how to say, you lost me on that. I don't actually understand what it is that you're saying, or what it is that I'm going through, or what it is that you're prescribing, just because there's such an intimidation and knowledge gap between these technical terms. And oftentimes care providers don't always perfectly understand where it is that what patients understand. So that's why I think it's amazing that you have that ability to just in really common language say, this is what prostate cancer is. This is what a PSA test is. This is why it matters. This is why early detection matters. So I'm just a real big fan of the mission that you're on.
I really appreciate that, and I appreciate having the platform. And what I think the one takeaway is to be careful, because I hear it all the time, as I talked about. Men, when you ask them, what is your PSA? They'll just say it's normal. And the reason they say it's normal is because their brilliant doctor, and who is brilliant in every way, told them it was normal because they read that on a lab test. But the lab test could be a 0 to 4.5 test. And remember, at a 4.43, mine was reported as normal when I had already been diagnosed as having prostate cancer by biopsy. So if you don't believe me that normal on a lab value really can be abnormal, take that message that I heard a guy who had been diagnosed by biopsy with prostate cancer, and 6 months post biopsy had a PSA level taken, and it was reported as normal. So believe me, know your number and get on it if it's above a 2.5 and start tracking it, because even if it's still at your lab being reported as normal, it very well could be abnormal and could be cancer. And detecting it early and getting, hopefully, I think prostatectomy, getting it out of your body in one little neat shell, you can be done with it and be cured. Otherwise, you could end up like me, metastatic disease, which I'll be fighting for the rest of my life, and hopefully be successful at it.
Right. Joe, thank you so much for your time today.
Okay. Thank you.